Welcome to the House Committee on Health and Human Services and Elderly Affairs. As is noticed, we have several bills we're going to be meeting and dealing with in executive session today. But before we do that, I'd like you to please join me in the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill for our consideration this morning is Senate Bill 85, and I'll ask for a motion. Representative Leon.
Thank you, Mr. Chairman. I move in expedient to legislate on Senate Bill 85.
Is there a second? Second. Representative Mazur seconds. Would you like to speak to your motion, Representative Leon?
Yes, thank you, Mr. Chairman. I greatly appreciate the intent of this bill. However, there were some words said in the committee hearing that make me say that we're not ready to do this. It spoke to a self-declared mental health emergency. While I recognize that people need to have care in those situations, we can't have a large change to insurance regulations based upon a self-declared health condition. That goes against the way that we practice medicine, and especially when we're looking at prior authorizations and a huge change to our insurance program. Secondly, this is a bill that is trying to address a very, very needed problem, but I think that if we're going to be talking about self-declared mental health crises to then open up the door for a very, very, very large provision of services, I think that that's just too much, and I can't support an effort that is that broad.
Okay, other discussion? Yes, Representative Shapiro.
Thank you, Mr. Chairman. I would hate to miss out on this bill's what I see it as its major thrust, which is to take programming to deal with the waiting room boarding situation, which is the mobile crisis teams, and to form a commission that will study how we can make this a sustainable program financially. And I think without this bill, we don't have a specific group looking at how to fund mobile crisis teams going into the future. So I think that would be a very unfortunate issue with letting this bill go, with ITLing this bill. Secondarily, I would say that this is just a question to Representative Leon, which is, I know there's a provision in here about pre-authorization requirements for emergency care, but I'm not sure when you say such a, when you talked about changing insurance provisions, is that what you're referring to? And I guess I wonder how that is such a major change.
Thank you for the question. Most health conditions are not self-declared. They are diagnosed by a clinician, or there's a suspicion of they're treating the patient. Right now, I could do a finger stick and I could tell you that what my blood sugar is, and I could do fasting ones, but I can't self-diagnose about my diabetic situation. I can't self-diagnose about about being bipolar. I can't self-diagnose about any of these conditions. I think that a self-diagnosis in order to provide insurance coverage, especially because we have other areas that are talking about other coverage. So if you come in with anxiety over my X situation, that would then, I feel that would then have that umbrella of the anxiety over a certain given health situation, basically include any care that they feel may be necessary in order to deal with that self-diagnosed anxiety over whatever medical situation they bring. Our job is to make sure that when we expand things, we do them within controlled guardrails, because once we've established a position, it's very hard to say, well, we actually didn't mean to include that area, because then we're picking and choosing winners and losers, and that's not what we're trying to do. I just want to make sure that our healthcare system that is, it is under a lot of stress, that we're balancing the needs. And I do appreciate that the commission is an important structure. I do have May I speak to the commission?
Sure.
Within there. The commission, it's yet another bill that we're seeing where it ignores statute that we have, RSA 1449. That statute was designed so that when we have commissions that are giving legislative opinions and that we view we view with a lot of emphasis here in the House and in the Senate, that is made up of over half legislators and not more than 15 people. We can get into the situation, and I'm not speaking to this makeup of this committee, but we can get into the situation where viewpoints tend to be aligned towards expansion of services without looking at the other costs to other areas and what other services we're not going to be able to provide in the state if we expand one area. So that's why there's the focus on having more legislators. This is one of the areas that probably will come up under the Commission on Commissions because we've seen at least 2 bills come over from the other body that give themselves an exemption from RSA 1449. I don't think that that's good policy, and while I appreciate the intent around this commission, I know that I personally can't support ignoring our established law just for convenience.
Follow up.
Can you point out specifically where the bill talks about self-diagnosis or self-declared diagnosis?
That was in the testimony that was provided to the committee. So when those who were supporting this bill and were part of the drafting of the bill were asked about what meant as a sudden onset of a mental health condition, that was a self-described, self-diagnosed mental health crisis.
Follow up.
Yeah, I'll drop it after this, but I would just say, as someone who's used to fill in as an emergency services worker for the local mental health center, it was never a matter of individual patients making their own diagnosis. We were talking about, in those days, people who came to the emergency room, and these days, hopefully, sometimes it's at home or school, where a clinician who is in consultation with a psychiatrist is interviewing people and making diagnoses and making a plan for services, and they are the ones that are in communication with the insurance companies. So I don't think the reality on the ground is about people making their own diagnosis. But anyway.
Representative Lay, on your response.
Thank you. And as one response, that's the problem around this. If you think that you are having an anxiety attack, and you go in expecting that it'll be covered, but then they tell you, no, you're not having an anxiety attack, you're having something else, which isn't covered by your insurance. Now you're on the hook with that emergency services bill. And I think that that's one of the things that they were trying to address with this bill. So this is just part of that challenge.
Representative Weber and then Representative Nettlerup.
Well, I appreciate the discussion and I appreciate the concern based on what people said at the hearing, but it's not what the bill says. What the bill says is that whenever mental health services are covered, and community crisis intervention services that otherwise meet the definition of emergency services set out in RSA 417 F1, it shall be treated as an emergency. And what we're doing here is simply extending the emergency services definition that currently applies to a licensed hospital emergency facility to the mobile services. And the definition of an emergency service, which is already in the statute, requires that before there's coverage, there has to be serious jeopardy to the patient's health, or serious impairment to bodily functions, or serious dysfunction of any bodily organ or part. So there is a very stringent guardrail already in place. And the only thing that's changing if we adopt this bill is where the deliveries of service occurs. It happens closer to the patient and not in a hospital. So for that reason, I don't think this is likely to result in claims for, oh, I'm feeling a little anxious today and maybe I'd like to talk to somebody. It's not that kind of a situation. It's emergency services, and they are well-defined in statute already.
Representative Land?
Thank you, Mr. Chairman, and thank you for that. That's definitely section 5, but in section 4, it changes the definition of emergency services, both for the freestanding and the brick and mortar. So if you would support removing section 4, which is page 4, lines 8 through 15, to go with the existing definition, I would be more favorable to support this bill. However, a change in definition for emergency services that impacts not only our mobile service, but also all of our established facilities, I think is far too broad to do without without very, very detailed discussion. And since that wasn't brought up in our commentary here, I think that we may have underestimated just how far-reaching this change could be.
Representative Weber?
But the definition is still, let me just see. Okay, I'm just working my way back through this. And then the introductory paragraph of RSA 417F1. I think there's certainly opportunity for greater clarity, but as I read it, the introductory paragraph would be the top part and the conditions would still remain, but I can see what your point is about the definition. If you would be willing to pass the bill with section 4 taken out, I'd certainly consider that. I don't know, I'll leave it to other people who are more versed in the area in case they have an opinion, but I think that might provide something of a way forward.
Yeah, Representative Nutter Upham, did you have your hand up earlier on? Oh, okay, all right, thank you. Representative Hall, yeah, go ahead.
I do, thank you. I'm looking at section 3, and my question on section 3 has to do with the makeup of this committee, or the study commission. I thought study commissions needed to have a greater percentage of members of the legislature. Am I mistaken on that, or is it only study committees?
Representative Weber?
My understanding is that a committee is made up of only members of the legislature. A commission is made up of members of the legislature and others, and I see our researcher is nodding her head, so I'm feeling a little more confident in that.
Representative Cushman?
Thank you. The statute that Representative Leon was referencing, which is 14:49, it does state that the legislative members shall constitute a majority of the commission. I haven't counted them, but that may be what you're thinking of.
Representative Hall?
If I may follow up, what I see here is the number from the House and the Senate, right, is 4, and then there's various departments represented, but there's a number of private organizations that are there, private nonprofit in some cases, that represent a larger percentage, and I wasn't sure whether we had to fix that or not.
Could I ask for the statutory reference again, please, Mr. Chairman?
Sure, Representative Cushman, what's the statute?
It's in Title 14:49, and it's item C.
2C.
Oh, 2C, thank you, yes. Oh, sorry, I thought you were passing things over.
14.
I can read it. I can read it if,
I'm a visual person rather than an
but-
auditory person, I think.
may I read it for everybody else? Okay, so 1449, Roman numeral 2C, no commission shall have more than 15 members and may include appointees who are not members of the general court. The legislative members of the commission shall constitute a majority of the commission. The term of the members of the general court who serve on the commission shall be contemporaneous with the term in office unless they are appointed in a capacity other than a legislative office. So what I see is the majority of this commission is not members of the court. So I think we have to make a change to section 3 if this is moving forward.
Certainly sounds that way. Okay. Representative Cushman.
Thank you, Mr. Chairman. Just one other point that makes me very, very hesitant to move this bill forward at all is we are expanding insurance mandates, which is something on principle that I'm not comfortable with. And this would broaden it to significant new services that are required to be covered.
Other comments? Representative Hold, you just put your microphone on.
I did, thank you.
Okay.
In this committee, what is the process for a vote, right? I believe there's an ITL motion, which would solve all of the issues that have been brought up so far. I believe Representative.
Calling the roll when discussion is over, when debate is over. Any other Representative Shapiro?
Just in response to Representative Cushman, I'm not sure that this actually extends insurance coverage at all. It just, it maintains the same coverage, but eliminates the pre-authorization for that coverage. I don't think it increases coverage.
Representative Leon?
Thank you, Mr. Chairman. For the benefit of everybody, can I read the emergency services definition, both how it stands and then how it would stand with the bill?
Sure.
It currently reads, emergency services means healthcare services that are provided to an enrollee, insured or subscriber in a licensed hospital emergency facility as by a provider after the sudden onset of a medical condition that manifests itself by symptoms of sufficient severity that a prudent layperson with average knowledge of health and medicine could reasonably expect that the absence of immediate medical attention could be expected to result in any of the following. What this bill does when it's amended is it adds or set out in section 5, which would be 415-5:5. And that's the one for the mobile services. And so I think that actually if we were to amend that section, to me, that would make sense if our intention is to have more mobile outreach. But so it would read, in the licensed hospital emergency facility or these no mobile trucks by a provider after the sudden onset of a medical or mental health condition or substance use disorder that manifests itself by symptoms of sufficient severity that a prudent layperson with average knowledge of health and medicine could reasonably expect that the absence of immediate medical or mental health attention could be expected to result in any of the following. And so that expands it to both not just medical, but also mental health and substance use disorder, which is a very large expansion. Maybe necessary, but very large. And we're not the committee that usually deals with insurance.
Other discussion? Seeing no other discussion? All right, I'll ask the clerk to call the roll. The motion is ITL on Senate Bill 85.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Hool,
Yes.
Representative McLean. Yes. Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Representative Pelosi,
Yes.
Representative Weber,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Priest,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant, not here. Representative Murphy,
No.
Representative Lanza,
No.
and Representative Tejas,
No.
and Representative McDonald.
Yes.
All right, so it's for 10 to 9 to 1.
Okay, so the motion passes 10 to 9.
Yes.
Okay. It does not have to be an absolute majority, right? Just, okay, so 10,
People vote.
so 10 to 9. So the motion to ITL passes 10 to 9. Okay,
Minority report.
so I assume there's going to be a minority report on that?
Representative Shapiro, I think, is nodding his head.
Okay, thank you, Representative Shapiro.
And his motion would be as amended.
There isn't an amendment.
Okay, just ought to pass.
Okay, moving on. Next up is Senate Bill 87. Do I have a motion?
Yes, I would like to pass out an amendment, if I may, Mr. Chairman.
Sure.
And I'd like to move the amendment and then ought to pass with the amendment.
Okay.
And if I may, Mr. Chairman, it's a very simple amendment, so I will.
I can see, yeah, go ahead.
There was a significant amount of concern when we were discussing this bill initially about the supervision for the nurses who were not yet licensed. So my amendment simply changes the language to say the individual, meaning the student nurse that's not yet licensed, has direct on-site supervision while providing healthcare services, because we were a little anxious about whether the supervision would be right there. And what we were told at the time was some camps are large enough to require by statute more than one nurse. And we felt, or I felt, that it was reasonable in that circumstance where you have a licensed and experienced practitioner on site, that one or more of the other people who were caring for the campers could be nursing students. And so for that reason, if you will permit, I would move Amendment 1458H.
Thank you. Is there a second to the motion? Yes, Representative Nutter Upham, seconds. Any other discussion? Seeing no other discussion, the motion on the floor, I'm sorry, go ahead, Representative Leon.
Thank you, Mr. Chairman. I think that this is great that we're getting to this agreement here. We know that the healthcare shortage is really impacting things, and especially with our summer camps, we're trying to get back to normal. And the more that we can get people in so that kids can get back to their summer camps and get people back employed in this profession, it may be a reentry for some of these nurses as well. So I think that this is a wonderful outreach, and I'm very happy that we're doing this.
Okay. Other discussion? Seeing no other discussion, the motion on the floor is ought to pass on Amendment 1458H. I'll ask that the clerk call the roll. And it is to Senate Bill 87.
Representative Leon,
Yes.
Representative Cushman.
She had to step out.
Oh, I'm sorry. Representative Bill King, yes. Representative Hool,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel.
Yes.
Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Priest,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant.
Yes.
Oh, he's here. Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-0.
Okay, the amendment passes 19-0. And now do I have a motion ought to pass as amended? Representative Weber.
Thank you, Mr. Chairman. I would move ought to pass as amended by Amendment 1458H on Senate Bill 87.
And is there a second? Representative Nutter Upham seconds. Any discussion? Seeing none, if the clerk is ready, I will ask that they call the roll.
Representative Leon,
Yes.
Representative Richmond, not here. Representative Bill King, yes. Representative Kofal, I'm sorry, Representative Hool,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Yeah. Representative Pelosi,
Yes.
Representative Weber,
Yes?
Representative McKay,
Yes.
Representative Freitas,
Yes.
and Representative Priest,
Yes.
Representative Nutter Upham.
Yeah.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-0.
May I move consent, Mr. Chairman?
Absolutely. There's no objection? See no objections. Okay, next bill up is 127, and discussions with a number of committee members. We're going to continue that to next week.
Okay.
Yes.
Representative Weber?
I just wanted to alert the committee that I have an amendment to the very first part of that bill. And I don't know if people want it passed out now or would prefer to hold it until next week.
Should we take a look at it?
Sure.
I'd be glad to pass it out at this
Okay,
point,
sure.
just so people have it and can. I think I'll do it this way. That's the larger one. I would, if I may, Mr. Chairman, just state that all it does is address the concerns from Representative Edwards, who had concerns about the fees that were assessed.
Remember.
The language was confusing. DHHS kindly clarified for us exactly what they do, and this amendment reflects exactly what they do. They charge $1,000 as the initial fee, and then every year after that, they charge $8 a client. And that has been in place for some time. And I can represent that the amendment was acceptable to Representative Edwards and to the department.
I remember seeing the email exchange between you and Representative Edwards, so thank you for doing this.
You're welcome.
Okay. Representative Leon.
Thank you, Mr. Chairman. I think that this is definitely an important part to clean up, and it's very nice. Thank you, Representative Weber, for bringing us this language. I know that we're going to continue the rest of the bill. I wonder if we want to deal with all the amendments later, probably, so that it's cleaner, or if we'd want to adopt this one, because while this is not an 86-part bill, it still does have a lot of different moving pieces to this one, which is why we need this additional time to make sure that we don't unwittingly pass something through that we later regret. So I don't know which way you'd rather go.
I would suggest that if other people have other amendments to other parts, and I'm sure that Ms. Dyer will correct me if I'm wrong about this, my understanding in the past from OLS has been if all the amendments are to separate pieces of the legislation, then OLS at the end can take each piece and incorporate it into one whole. If there are other amendments to this particular section, then it would be better for whoever wants to amend it to incorporate this language as well as whatever other amendments they want. So I don't know what people are bringing in terms of other amendments, but it would be useful to have that perhaps put off for later so that it's all part of a whole.
I would think so, too.
That works for me. I just wanted to question, since I know we had OLS working overtime last year when we had our multi-part bill.
I'm sure.
Okay, any other concern, yes, Representative King.
Thank you, Chairman. If this new amendment does get added to a bigger part of other amendments, I just want to note that based on my reading of it, it does look like it will actually change the definition and the fee structure. Because beforehand, it said that if you're a new provider, you're going to be paying the $1,000 plus $8 per client. So your very first year could be well over $1,000, whereas the new language, it makes it sound like if you're initial, it's only $1,000, and after that, $8. So it could very well be that your very first year could be several $1,000 based on the old language. Based on the new language, it doesn't matter how many clients you have, it's only going to be $1,000. So it does appear to change the actual definition.
It does change the actual definition, which was unclear, but what I was told by DHHS is that this is the way the statute has been implemented. And as long as this is what we're already doing, I thought it was more prudent for us to say it up front and to say it more clearly, because there was a great opportunity to misunderstand the earlier one, as we'd all read it in different ways. So.
What's that? Representative Hall?
Thank you. Just reading this as a follow-up to Representative King, I guess I could interpret this if there was only, 50 clients, the subsequent fees would be only $400, correct? Okay.
I believe that was related to the startup costs of getting programs up and running, and that after that, it was then dependent simply on a maintenance level.
Okay, we'll go to 171. 200, right? Okay. All right, we're going to skip over 171. We will be going back to it. Again, we're going to continue 127 to next week. Moving on to 200. I'm actually the co-sponsor, one of the co-sponsors of that bill. And Representative Leon, do you want to recognize me for a motion?
Yeah, so if we have an amendment, should we
that's
do
right.
the amendment first?
Yes, that would be appropriate. Representative Palazzo.
Yeah, I would like to offer an amendment and speak to it. It's being distributed right now.
Could those of us who have not had a, oh, did you pass it out?
Yeah, they're coming around now. The amendment is coming around now.
So, thank you. And now that everyone have it, so the original bill relative to optometrists.
Representative, why don't you move the adoption of the amendment first?
I'm moving to adopt Amendment 2023-1451H to SB 200
To pass?
to pass.
Is there a second? Representative McLean seconds. Representative Palazzo, you'd like to speak to your motion?
Thank you, Mr. Chair. The original bill gives additional medical freedom in relation to certain injections made by optometrists, but there are some concerns about safety of some of the vaccines listed in the original bill. So I offer amendment 1451H, which addresses both of these issues. So in terms of giving more medical freedom and address certain illnesses that can cause eyesight. So we have testimonies that shingles vaccine might be important in terms of addressing vision issues. So I specifically left that vaccine and I added another 11 vaccines. So it's like 4 times more than original bill. Those vaccines that are well tried and have well established knowledge about how effective they are. At the same time, if you look at 3Q, I'm ready to open it up for more vaccines, but give some waiting period until July 1st, 2025 for some other vaccines where it's either unknown efficiency or known concern of side effects. So specifically Haemophilus influenza vaccines, we know that we can't predict how effective it will be until next wave of this highly mutating virus. So that's why I felt it shouldn't be in the original list of vaccines. And the second one is COVID-19 vaccines and other vaccines that use the same technologies. Science on COVID-19 vaccines have not been settled completely. It's keep changing. Certain countries like Switzerland just moved to pause administration, and here it took almost 2 years for our DHHS to recognize the connection between COVID-19 vaccines and myocarditis. Just recently, guidance for small kids changed from 2 adult doses. It went to 1/2 dose. So why did it happen? It's either medication was too effective or too dangerous. And we know that COVID-19 vaccines don't stop the transmission of the virus. So it's not about effectiveness, it's because there are some dangerous side effects. This bill does not deal with kids, but for example, CDC data for New Hampshire shows that 4 times more minors died after COVID-19 vaccines here than after COVID itself. And in relation to optometrists, my concern is that some of the reported effects from COVID-19 vaccines were actually eye disorders. In April of last year, there were over 8,000 eye disorders reported, and it might be because there are some microstrokes and we don't know. There are different theories why those side effects, like many people think that it's because spike protein is toxic, and I put that language. Lipid nanoparticles, I saw data about New Hampshire resident who died in Massachusetts hospital with allergic reaction to phospholipids. So I think it's important us to wait 2 years and see what's causing. But another theory that might be true and might be not, that it's important how we administer this COVID-19 vaccines. If suddenly larger portion of vaccine goes to bloodstream and ends up in tissues where it was not intended, maybe that's what causes side effects in some small percentage of people. And I'm mentioning it because we are bringing new group of people who will be administering these vaccines with less training than those who are administering it now. So those concerns are important. So that's why I'm saying practice on those 12 vaccines that are known, and then after this period and after science settled, you will be able to administer those vaccines that are new and have some known side effects. Thank you, Mr. Chair.
Thank you. Other discussion? Any other? Representative McLean? Did I see a hand up?
Yeah, well,
Okay.
thank you, Mr. Chair. I'm inclined to support the bill and the amendment. I think what the bill does is it expands access to vaccines. One of the things I know from personal experience, when I tried to get vaccinated for the COVID vaccine, I contacted my PCP because I wanted to have a discussion, and I couldn't even get through. The nurses were basically the guardians. They said, no, you have to go to a clinic. When I went to the clinic, you couldn't have any really comprehensive discussion at all. This, I think, at least, an optometrist is a physician. It gives you an access, and they would be trained as a part of this. So, it gives you an opportunity to have increased access to both the vaccine and to those discussions. So I think it's good. I did get some emails from constituents. A lot of my constituents have a lot of vaccine hesitancy. Because of the way that kind of things were rolled out within the pandemic. So I think what this amendment of Representative Polozov does is it allows you to basically get this in, get it going, but some of those vaccines that are newer and more controversial, it kind of just puts a hold on them for a little bit so that we can get the program established, and it sunsets in 2 years. So the impact of that is marginal, but it does allow things to get established, and those other vaccines will be brought online in a couple of years. So I think it's a good amendment, and I think the bill underlying is good as well, and I'll support it. Thank you, Mr. Chair.
Representative Murphy, did you have? Yeah.
Thank you. I would tend to agree with the idea that the availability of increasing access to a vaccine through the optometrist's office is a reasonable concept. I had my questions about the bill, the original bill, and some of the effects it might have, but certainly increasing the access to having a vaccine for a pandemic or an epidemic is critical going forward. And it is not to say that any of these vaccines that you have listed in the amendment are without side effects. I mean, every one of them has side effects. We've kept in the shingles vaccine. One of the most devastating complications potentially of shingles vaccine is Guillain-Barré syndrome. And so, it's not like these vaccines are without their risks. I also am concerned about the hesitancy about specifically addressing vaccines that are based on the newer technology, the mRNA technology. Really what that technology did was to accelerate the safety process of developing a vaccine. So if you are totally against all vaccines or any vaccines, that's your prerogative. But to dismiss all vaccines or any specific vaccine based on the technology, which is new and different, I think is somewhat concerning. The last thing I would say is that the intent of the bill also was to have a vaccine available during acute outbreaks of either pandemics or epidemics. You don't have a lot of time in which to, and the reason they didn't have this bill 2 years ago is it would have taken time, and by the time that they can get access to given the vaccine, those that could be qualified to do so would, the pandemic or epidemic could be passed by that time. So I think that, the intent of having influenza vaccines and COVID vaccines specifically were meant to address very acute episodes of pandemics and epidemics in the environment. And so I just cannot support a bill that targets these specific vaccines based on either the technology used to make it, and is specifically targeting those vaccines which are meant to acutely address pandemics or epidemics going forward. So, thank you.
Thank you. Representative Merchant and then Representative Weber.
Thank you, Mr. Chair. Fundamentally, I support having greater access to vaccines for the public. My concern here is that, which we heard from the optometrist, was starting slowly. Given all the vaccines at one time does not give somebody the opportunity to go down the road with a few vaccines. I think influenza, quite frankly, is probably the least problematic of all the ones, but it's going to be withheld until 2025. So I would say at this point in time is we're looking at trying to encourage the optometrists to give a vaccine. The most common one that's given out there is influenza. However, if you look at the amendment, you really can't give influenza until 2025. So in a lot of ways, they're not going to have the opportunity to give the vaccine, which is probably the most safe vaccine, to again learn how to give vaccines and go down that road. If I look at it from a public safety point of view, is I'd rather have them start slowly, but also include vaccines like influenza in order for them to get a learning curve. Once they go down the road, I would say in 2 years from now, then expand the vaccines to all the vaccines. But that's my concern, is that the most safe vaccine listed is the one that they can't even give until 2025.
Representative Weber.
I would concur with what Representative Merchant said. And the other thing is I'm bearing in mind the words of my colleague who normally sits next to me about sort of free market, allowing people to access and make their own decisions. And that's what the original bill was. And again, it was to create access, particularly in times when greater access was needed. What this does is it removes the greater access for 2/3 of the things that were asked for in the original bill and adds a great number of things that were not asked for in the original bill. And while I understand the concerns that Representative Polazov is addressing here, I think that people get to make their own decisions, and it's not as if anybody's forcing anybody to go and get a vaccine at an optometrist's office. It is a choice that people make, and if they have any concerns about either influenza vaccines or COVID vaccines, I would hope that they would simply abstain until they have satisfied themselves that this is the right vaccine for them to be having. I would prefer to leave that in the hands of individuals rather than in the hands of the legislature. So for that reason, I'm going to oppose the amendment because I think it really guts the original intention of the bill. Thank you.
Representative Leon.
Thank you, Mr. Chairman, and thank you for this lively discussion. I think it's wonderful to see how far we've come in the last few years, that now both sides of the aisle are recognizing the people's right to make their own decisions about what drugs and pharmaceuticals and vaccines they think are appropriate to take based on the level of data. I want to address Representative Murphy's concerns about sort of the vaccine hesitancy around the mRNA vaccines. So it's not really a concern from what I've seen with the hesitant community that it's a 30-year-old new technology. The big concern is that the initial approval of the mRNA vaccines collected less long-term follow-up data than was actually described in the original clinical trial design. And the big concern, I'm using FDA words, even though a lot of people in the community don't use FDA words. The big concern is that that initial trial will be used as a predicate approval to allow all future mRNA vaccines to be approved without their own standalone human safety study. So this is all comes down to a concern around that original predicate approval. We were in a crisis. It made sense to allow that crossover and to allow less data collection at that point because we needed to bring something to market so those who wanted to would have a choice. We're past that initial crisis, and so the big concern is to make sure that we're not using that as a predicate approval. So I just want to make sure that that we understand that it's more about the process and the fact that that approval shouldn't be the building block for all future vaccines, as opposed to a resistance against new technology. And then as far as the amendment, I really appreciate the how it was brought forward and the fact that we're trying to address these concerns. To me, I think that the limited one that we initially had as the bill does give a smaller step into it. And I do think that we need to address not allowing that initial trial to be a predicate for anything that's mandated in the state, and that we use caution around any that's built off of that predicate. But I think that we can address those concerns in a different way. So I'm in more support of the underlying bill. So unfortunately, I won't be supporting the amendment.
Representative Shapiro, did you have your hand up earlier? No. Representative Nagel.
I just wanted to point out something. Basically, influenza, as you say, is the most commonly prescribed vaccine. It's actually been totally eliminated. Haemophilus influenza and influenza are not the same thing, totally different things. So I'm just curious why the flu vaccine was totally taken out of this.
Representative Polazov, did you want to respond to that, or?
So the only two things comparing to original one was temporarily removed, not completely removed, but temporarily removed COVID-19 vaccines and Haemophilus influenza vaccines. So maybe there was some issues with original bill that needs to be addressed.
Just so you understand, Haemophilus influenza is a bacterial, and the concern is that it can progress to meningitis. That's why a vaccination was developed, but it's not the same thing as the influenza vaccine, and it's unfortunate they have the same word, but anyways.
Okay. Representative Cushman. Oh, well
He
said.
made my point, thank you.
Okay, thank you. Representative Lanza.
Thank you for taking my just a statement. So I've given out many vaccines. I worked at Southern New Hampshire as a volunteer and so with the COVID pandemic that we had, and I did see a lot of people who did have adverse reactions. So in allowing the optometrist, I think we do need to proceed very slowly. I agree with what Representative Merchant said. We can't just forge ahead right away and go into allowing them to give everything out. And I think they have to also make sure that we have the availability to have epinephrine and everything else available within their offices, because we'd never know. And they also need to check with their own primary care physician prior to going to the optometrist and getting that, because if they've had a reaction on another vaccine in the past, they should not probably go to the optometrist and get that vaccine. They should actually go to their own physician. And that's where we need to really think about, being very careful about this.
Thank you. Representative Cushman.
Thank you. I'll try to be brief. You touched on something that's very important. It is sort of addressed in the bill. It's almost the same requirements on the optometrist as is on pharmacists, pharmacy interns, and pharmacy technicians, with a few changes one thing left out that I'll touch on later, not on the amendment. But so the amendment is kind of conflicting for me personally. On the one hand, I want to expand free market access to anybody who wants to try a medication or in this case, a preventative pharmaceutical product. And on the other hand, we've seen that the laws are kind of tipped in favor of quick approval of these things, and so there are some issues there. But to your point, it does require that they review the vaccine registry or other records before administering vaccination, and if everyone is doing what's required for that. The registry, if there's an adverse reaction, that's a vaccination event that has to be recorded in the registry. So there would be at least a cue like, oh, they've had an adverse event and it's here. And it does require that they give notice to the primary care provider when the patient designates one, just to let the primary care provider know that they received this so that they are on the same page and the main person following their care knows. But you're right. At the beginning, there's nothing really to ensure that they make that judgment, you know, saying, you've had an adverse reaction. I don't want to do this. So I'm just I'm torn on this. I would like to see a hold on the mRNA vaccines being administered carte blanche, just because of all of the issues that have been seen with the COVID vaccines, with the mRNA vaccines in general. And if we're gonna, approve successive vaccines based on that, it's concerning. So I'm very torn on this. And I'm not sure where I'm gonna fall on this amendment, but I do understand where you're coming from. And thank you for bringing it forward anyway.
Representative Palazzo?
There were some mixed reactions. I want to state that if we want to continue, I am open to change my amendment to include flu vaccine into immediately available to optometrists if there will be enough support from committee for that, and if not, I think we should move ahead with the motion.
Okay. Any other discussion or comment? Yes, Representative Weber.
Just one more comment about revising the amendment. I think we took very vigorous testimony at the hearing about the level of preparedness and precautions that would happen in optometry offices with the 3 original vaccinations. And I was convinced at that point that certainly it sounded to me like they would be administered safely, as safe as any of these administrations are in an optometrist's office, but we haven't heard about all of the myriad other things. So my comfort level would be much better served by sticking with the original bill.
Thank you. Representative Hall.
Thank you, Mr. Chairman. In reference to the amendment, several of those seem like they're children-specific for the most part. Mumps, measles, mumps, and rubella type things that are administered in a childhood schedule more so than adults. Secondly, I'm glad that it continues about referencing the adverse reporting system. I guess my concern stems from allergic reactions, especially in children, that you might not know this. I remember very distinctly seeing a nurse, right, someone who practices medicine who did a particular COVID vaccine as part of a televised broadcast and then collapsed into anaphylactic shock. And this is someone who routinely works in the healthcare industry and would know more so than the average adult what particular concerns they may have in their own health. So while I like opening up the free market, I think that's good, and I'm letting parents make informed decisions. In this case, with the ones that are children related, I'm a little bit more concerned than the primary care physician. I do have a question, and I don't know if this is the right time to ask relative to the original bill of the chair. Is there an appetite amongst the committee to modify Section 3, removing COVID-19 in Section O? This is a complicated one because this amendment doesn't exist, but I'm just trying to ask a question. And then including Section Q of Representative Palazzov's amendment, right? And the reason I asked that combination, we would have to go have that drafted, is there has been some reluctance to these new technologies. I do medical product design that pays the bills so my family can afford to eat. And I know what it takes to get a 510K submission for a medical device. I know how long and how rigorous getting approval through the FDA is for products that are on the market that you want to make a simple change to. And my concern is, and I think this is where the vaccine hesitancy came from, was some of the COVID technology was pushed through very rapidly, and I'm not sure it was vetted as well as it maybe should have. We definitely don't have any long-term data because it doesn't exist. And maybe putting that portion on hold would be valuable. So I guess if there's an appetite amongst the committee to make those two changes, I would offer to go get that drafted at OLS.
Representative Weber?
I will just say that I just had breakfast, so I have very little appetite. I am willing to go along with the bill as it was introduced. I'm still unpersuaded that a lot of optometry offices are going to do this. I am willing to go along with the original bill because it was what we were asked to do. But in the absence of more hearings and more input, I'm really, really uncomfortable changing the policy when we already have policies that include many other ways of getting these things and different ways under which they're administered. I don't think making things more complicated for the optometrists is actually going to increase access. So, the struggle for me was, do I want to extend access to the optometrists in a limited way? And I have come down to the idea that yes, I do, unless when we get to that discussion, I hear other things. But I am not comfortable at all going beyond the bounds of the original bill.
Thank you. Representative Leon?
Thank you, Mr. Chairman. And this is actually building off of Representative Hull's comment. I too, for a while, paid the bills in a medical technology related position. I actually advised investors on where to put their money. And quite frankly, if I had told anybody to expect an approval process as incredibly streamlined as we saw, I probably could have been sued for financial negligence. So we saw something that's never been seen before, was never really expected, and is so far outside of the process that continuing to drag some heels in about including more of the mRNA vaccines makes a lot of sense, because we've never seen approvals this fast before, and it would have been fiscally irresponsible. It would have been fiduciarily irresponsible of me to suggest that it was possible. I'm thinking that as far as we look at these different ones, I'm wondering if it makes sense for us to vote on this amendment. I'm not sure where we're all going to come down. It's quite possible that we may end up coming with I guess see where our position is about the more streamlined amendment that Representative Hull had. I don't know what Representative Polozov says, but if that's something where there's appetite, maybe that would be a position to take.
Yeah, I would be open to withdraw my amendment if we will move forward with drafting what Representative Hall suggested.
Withdraw that and then recess this one.
Mr. Chairman, could I suggest,
Yes, go ahead.
once we have dispensed with this First Amendment, we could certainly, as a committee, I believe, take a straw poll as to whether people wanted to proceed with Representative Hull's suggestion, and that might make it a little clearer as to what we wanted to do after that.
Okay, yeah. Sounds good. Okay. Any other discussion on this amendment? Seeing no other discussion? All right, so the motion is ought to pass on Amendment 1451H to Senate Bill 200.
Representative Leon,
No.
Representative Cushman,
No.
Representative Bill King, no. Representative Hull,
No.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
No.
Representative Pelosi,
Yes.
Representative Weber,
No.
Representative McKay. No. Representative Freitas,
No.
Representative Priest,
No.
Representative Nutter Upham. No. Representative Shapiro,
No.
Representative Merchant,
No.
Representative Murphy,
No.
Representative Lanza,
No.
Representative Tejas,
No.
Representative McDonald.
No.
4 to 16.
The amendment fails 4-16. As to another amendment, let's do a straw poll. Who would think that would be a good idea? What's appropriate, Representative Weber? Show of hands or?
I believe we can do a straw poll by a show of hands, and if the question is, if you put the question to the committee, should we pursue an amendment in the nature of what Representative Holt was suggesting, we'll get an idea as to how people feel about that.
Sure.
So for clarity, right, it was removing the COVID-19 section out of the original bill and adding language similar or maybe verbatim to section Q, 3Q of Representative Palazzo's bill, right, to put on hold any new technology is I think what we're taking a straw poll on, correct?
Sure.
Can I ask clarification?
Sure, Representative Merchant.
Thank you, Representative Holt. So basically, we're going to exclude, if you will, on line 12 of the amendment that Representative Palazzo, Haemophilus influenza vaccines will be taken out. Is that correct?
That would be correct.
They're leaving only COVID vaccines or the other vaccines. Is that your
Any other, Representative Tellez? And welcome back, by the way.
Thank you. I'm a little confused because my understanding is this bill's intention was to expand access to COVID vaccinations and influenza, like a lot of other practitioners who don't traditionally give vaccines were approved to be able to do. And then what we're talking about now is removing COVID vaccination and influenza. Is that correct?
No.
Okay.
No. We're maintaining influenza, we're removing COVID.
Okay, well, so COVID, which is the primary thing. Yeah, okay, so, and both, yeah.
Representative Shapiro, you had a question?
I'm going back to the question that I think Representative Nagel had before. Where is the flu shot mentioned?
In the
No.
Representative Leon.
Thank you, Mr. Chairman. When you look to the original bill in section 3 on line 15, it adds influenza, COVID-19, and shingles vaccines, which have been approved by the Food and Drug Administration to adults. So the current bill allows them to administer the influenza, COVID-19, and shingles. We're doing a straw poll to see who would be in favor of an amendment to strike just COVID-19 from that line and to have something similar to section Q from the amendment, but we want to find out how much wordsmithing needs to happen,
So throw out the First Amendment completely.
other than Q.
Yep, okay, thank you.
Lanza.
So
Representative Lanza.
I apologize, Chairman. So because of the pandemic, and we're kind of past the pandemic, but we never know. Wasn't it set up for the optometrists to do this in the event that they would have to give some COVID vaccines to now all of a sudden not have? Now you're saying to take out COVID vaccines? It's a little confusing to me.
Representative Palazzo.
Could I just,
Representative Weber and then Representative Palazzo.
I just want to clarify the position for where we are. The original bill, for those who were not here for the original hearing, had influenza, COVID-19, and shingles. And all we are doing now is talking about a straw poll to find out whether it is worthwhile to pursue an amendment of the sort that Representative Holt is talking about. I wonder, Mr. Chairman, if it might be simpler at this point, because we don't see it in front of us, to simply see if an ought to pass motion might pass, which would get the whole thing taken care of. But I do understand the need for people to discuss other alternatives, which is why I'm certainly willing to go along with the straw poll notion. But after that, I'm hoping that we'll have a clearer direction.
Representative Leon.
Thank you, Mr. Chairman. I think that for some of us, the question is in between ought to pass as amended versus ITL, but between ought to pass or ought to pass as amended by this potential amendment.
I understand that.
So-
That's why I said that.
Yes, I appreciate that. Maybe we should go with that straw poll of who's interested in pursuing that pathway. And then we will know what to do.
Representative Palazzo?
I want to address Representative Tia's question. So this bill has several parts and several motivations. Today we learned that originally it was motivated by pandemic, but when we were hearing this bill in here, what optometrists testified that they don't get requests for vaccine. Nobody asks them if you can provide vaccine. And they also testified that they specifically want shingles vaccines because shingles sometimes related with vision. So it's not necessarily that the whole bill based solely on COVID vaccine.
Thank you. Representative Merchant?
Thank you, Chair. Just to make people aware of the fact is when this was coming to us, part of the reason why the optometrist wanted to be given the authority to immunize was the fact that they wanted to go to help out with the COVID clinics. And they couldn't because they had no authority to give the vaccine or any vaccine. So that was one of the triggers in which they wanted to, at that point in time, come to here to the legislative body asking for permission to give the vaccine so they could actually participate in the COVID vaccine immunization clinics. Number two, there is movement afoot to incorporate the COVID vaccine into influenza on an annual basis. So I'm not sure where that's going to go. If we take out the COVID and we leave them to have the influenza, if they don't have the ability to get influenza all by itself, because that's what the manufacturing community is doing, it may in essence negate them given the ability to have the influenza because they won't be available in the marketplace. I don't know where it's going to go, but there's been discussion by the manufacturing community to incorporate COVID into the influenza because they believe it's going to be seasonal.
Representative Leon?
Thank you, Mr. Chairman, and thank you for that insight. That actually strengthens my support of this amendment because if the state legislature puts forth the need for industry to keep a separate influenza vaccine, I think that that's a great benefit to public health and individual choice. So,
Any other discussion? Ready for a straw poll? Those in favor of some kind of an amendment along the lines of Representative Hull's discussion? Who's counting? 1, 2, 3, 1, 2, 3, 4, 7? Okay. And those opposed? So 7 to 13? Okay, Representative Weber?
May I be recognized for a motion?
Sure.
I move ought to pass as originally presented to us on Senate Bill 200.
Okay, motion's been made. Is there a second?
Second.
Okay. Representative Priest seconds. Any discussion? Representative Palazzo.
I'm very concerned about the about SB 200 specifically making motivation for optometrists to provide COVID-19 vaccines. We had testimony that they are not concerned about possible side effects of COVID-19 vaccine if they have a patient with vision issues and maybe circulations in issues causing eye problems. From testimony, it sounds like they never asked if it was a result of vaccine injury. And we are putting them in a position where they will be even less motivated due to financial and other obligations in this situation. I'm very concerned about this bill. The large quantity of problems that followed the mass administration of COVID-19 vaccines circulation-related deaths went up, blood-related death codes went up in heavily vaccinated communities such as Massachusetts. So I'm opposing to this bill as written.
Thank you. Other discussion? Representative Mazur.
Yeah, as mentioned previously, people have said, and I am up about free market, free will, all of that. The deal breaker in this bill for me is the COVID-19. Because of, I mean, I voted previously, you know, on a bill that expanded access and distribution of vaccines. I voted against that. So I'm going to continue to do that because of the issues in particular that I've seen with COVID-19. I have many, many friends and family members who have had very severe adverse reactions to this vaccine. So if that wasn't in this bill, I would vote for it. That the mention of that particular vaccine is why I will be voting against this.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. I am going to be voting for ought to pass. I am ambivalent about because I don't see any great need to have optometrists be giving vaccines right at this point, but I don't see any harm in it either. And I would just say that I'm kind of frustrated and sad that we're using this bill to relitigate the efficiency and safety of the COVID vaccine. It is already available. It is legal. People have the choice whether to take it or not. We're not changing any of that. We're really just saying that this one group of people who seem to be capable of doing it safely will be able to give the vaccine as well as many other people. So I'm going to vote for it.
Thank you. Representative Leon and then Representative Nagel.
Thank you, Mr. Chairman. I'm glad that we have reached the point where most people are not forced to take the COVID vaccine. However, people who are working under an employment agreement that's mandated by CMS still need to take it. So I think it's important to note that. I think my largest concern with the bill as it stands is the same one that we had on the pharmacist with the RSV. We need to come back and figure out how to put requirements for VAERS reporting. And I want to make that note that I see Representative Merchant also nodding his head. This is a bill that I'll likely have more support for the amendment that will be likely drafted as a minority report, but I believe that increasing this access is important, so I'll be voting for the bill as ought to pass, even if I may end up liking ought to pass as amended even more.
Representative Nagel.
Thank you. I've had an incredibly interesting life. I've gotten to practice medicine all over the world and places where I did things I had absolutely no right doing what I was doing, but there was nobody else there to do it, so I did it. Last I checked, this is not that environment. One of my fondest memories of childhood was getting allergy shots on a regular basis. And I'm on every other week basis going into anaphylactic shock. And it's really entertaining to have your throat close and have your skin get all itchy and scratchy and all sorts of stuff and being 9 years old and having no clue that you're about to die. But the good news was that my doctor knew exactly what to do. He grabbed some epi, threw it in me, and the nice news was that because it was in his own house, I had to stay for 2 hours after, and I developed a nice lifelong friendship with his daughter, who I played with while I was recovering. The moral of all that story is that I really am struggling with the level of confidence that I have in certain people to manage things like that. It's nice to know that I have a doctor that's been trained how to do this, not just taken a course in basic life support or whatever and never really experienced it, but actually practiced it under supervision on a regular basis in real life circumstances. And that's why I'm really struggling with allowing interventions of this kind to be done outside of the medical realm by people that I'm not totally convinced are qualified to do it. I think the other thing is that if we had a clear, compelling public health reason to do this, then I would say, fine, we really need to do it. The benefits outweigh the risks, but I don't think that case has been made, and that's why I'm not going to vote for this.
Other discussion? Representative Cushman. And then Representative McLean.
Thank you, Mr. Chairman. So I'm gonna use what you just said, Representative Nagel, as a springboard to some concerns I have about the bill. When we did give the authorization to pharmacists, pharmacy interns, and pharmacy technicians to administer vaccinations to adults and a couple to kids, we ensured that they would provide proof of that additional instruction on an injection technique and evaluation and managing treatment of emergency reactions to their board. And I don't see any language that would require that here. And it's also unclear to me whether optometrists, as part of their licensure, are required to maintain a BLS certification. And without, so if anyone has the answer to that question, I'd be happy to have it. But those are just a couple of concerns that I still have about this. And then, of course, the elephant in the room is that the adverse reactions are not being reported when they happen. And so for that reason, I'm not sure where I'm going to fall on this vote. I'm probably going to make up my mind in the second before we do it. Again, those competing concerns where I want to increase access to things for people who want them, but at the same time, are we ensuring that we're having a level of education for these people who are administering them that's appropriate? Thank you.
Representative McLean.
Thank you, Mr. Chair. I mean, and I do have some concerns about the bill, but I do think it expands access. And for me, looking at it, I think an optometrist is as capable, if not more capable, of administering the vaccines than some of the drive-up Catalines that we saw with respect to COVID administration, where it was impossible to have a conversation. It was really incredibly frustrating for me. I ended up not getting the vaccine. And where I couldn't get access to my PCP to have it done, I would have appreciated this as an alternative. There will be training that comes along with this. And I don't know that this solves all of the VAERS problem that we talked about last week, but I think there's probably going to be more of a chance of compliance with the optometrist than there would be in the drive-up Catalines. I don't think it solves the problem. I think we still have more work to do with respect to that. But taken as a net negative and a net positive, I still feel that this legislation is a net positive, and so I will be supporting it. Thank you, Mr. Chair.
Thank you. Other discussion, Representative Merchant.
I wanted to follow up on Representative Cushman's comments, and I think the points are well stated. And I'm going back and looking at the requirements placed on the pharmacist, and you're absolutely correct. The pharmacist actually has to demonstrate to the board they have received the appropriate training, and in the training itself talks about basic life support and things of that nature which they have to maintain. That is not the case at all with this bill with the optometrist. So in saying that, I would be willing to sit down with Representative Cushman and possibly work on an amendment to this to be sure that those requirements are actually built into this as well. Because it goes back to what Dr. Nagel, or Representative Nagel said, you need to have the training to deal with an emergency. And if you don't have that training, just because you have some certification and so forth, you should demonstrate that to the board that you're responsible to, which would be in this case the Board of Optometry, that you in fact have not just passed the course, but you have also maintained BLS training and so forth. So I think it's an important point.
Representative Weber.
Having listened to this discussion for a very long time, I think that if the agreement is that an amendment would be drafted that deals solely with training and with VAERS reporting and not with any of the other stuff, I would be willing to withdraw my motion if the second is willing to withdraw the second, and this could be addressed again at a further meeting.
So there's a yes. Representative Priest. Okay, so continue this then. Is that what I'm hearing? Continue it till next week?
And Mr. Chairman, can I ask what happened to 171?
Oh, we're going to go back to it in a moment. Yeah, we just went a little bit out of order.
Who is bringing the amendment?
Mr. Chair,
Representative Merchant. Go ahead.
If I may, I want to be sure, Representative Cushman, are you willing to work with me on the amendment?
Absolutely.
Thank you. It'll be amendment from both Representative Cushman and myself.
Okay, any other questions or discussion before we move on? So we're going to continue SB 200 to next week. Going back to SB 171. Do I have a motion? Representative Weber.
I drafted an amendment based on some discussions that we had. May I pass that out?
Sure, go ahead.
The amendment deals solely with the reference to school-age children. And you will remember that when we heard the bill, there was a proposal, let me get back to 171, that we incorporate by reference a definition of school-age children, which occurs in RSA 170:2. And what that definition is children 4 years and 8 months of age or older and attending school. And so several people said to me that there was a little concern about that because it was in another place. And also there is the issue of people who are homeschooling and who might want to take part in these programs. So I thought that the "and attending school" might not be particularly helpful. So all the amendment does is it changes the language, which is now youth program for children 6 years of age or older, to program for children 4 years and 8 months of age or older. And that way we allow for the younger children, which was what the initial concern was. The initial concern was about children who are already in kindergarten but cannot participate in these programs. I thought that the 4 years and 8 months was just as good a cutoff as any. And because there was concern about having a definition about what we were talking about, I thought that this would satisfy a bunch of needs and would give us guidance as to the lower ranges of who may attend these programs and what the exceptions are, but without incorporating the school attendance restriction, which I thought was not needed.
So Representative Weber, you're moving 1455.
I beg your pardon. I am indeed. Thank you.
Is there a second?
I second.
Okay, Representative Priest seconds. Any other discussion on this amendment? Representative Leon.
Thank you, Mr. Chairman. My first thought was 4 years, 8 months. That's really young to go to the Boys and Girls Club. Then I did some math, and that's how old I was when I started kindergarten. Yeah. So I think I'm okay with this. And thank you very much for bringing this amendment. It provides great clarity.
Other discussion, Representative Murphy.
Yeah, am I mistaken? Thank you. Am I mistaken? But I thought when we met last that somebody mentioned RSA 170-E:2 actually defines that as 4 years and 8 months. Is that correct? Yes. So you're just taking that language and putting it into this amendment here.
What we discussed when we actually had the hearing was incorporating that statute by reference. And somebody raised a question about using that statute because it's actually the definition of school age for completely different purposes. And when I read it, I also saw that it limited the definition to children who were attending school. And I thought that the original statute here that talked about 6 years of age did not have that limit in it. And so I thought it might be more prudent simply to drag over the 4 years and 8 months, which gets all of our kindergarten students in, without dragging over the restriction about how they are getting their schooling. It just seemed a cleaner way of doing it.
Thank you. That's what I thought.
Other discussion? They say no other discussion. The motion on the floor is ought to pass on Amendment 1455H. I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Hool. And no vote. Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Priest,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
and Representative McDonald.
Yes.
19-0.
Okay. And do I have another motion on 171? Yes, Representative Weber.
I would move on to pass as amended with Amendment 1455H on Senate Bill 171. I'll get it right sooner or later.
Okay. Representative Cushman seconds. Any other discussion? Seeing none, I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Hull, still not here. Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Priest,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
and Representative McDonald.
Yes.
19-0.
There's no objection. We'll put that on the consent calendar.
Thank you, and I do good.
Thank you. Okay, moving on to Senate Bill 238. Do I have a motion?
I believe that there's an amendment. Do you have that amendment yet?
Yes, I would like to make a motion to,
This on the amendment, Representative?
yeah, the amendment, to introduce Amendment 1472H to House or Senate Bill 238. I handed it out to everybody earlier. Would you like me to speak to that motion?
Sure. So you're moving on to pass on 1472H?
I am.
Is there a second to that motion? Representative Weber seconds. Sure, go ahead, Representative Murphy.
Senate Bill 238 is actually a very good bill. It allows for telehealth prescribing, but it has a fairly narrow focus to mental health only. A few weeks back, we, as a committee, passed unanimously House Bill 500, which was allowing prescribing of Schedule 2 to 4 drugs to a much broader range of patients. To put it in perspective, you know, the number of patients that are having telehealth appointments at just DH alone are now over 1,500 a day, where before the pandemic 3 years ago it was only about a dozen a day. The satisfaction among patients has been as good, if not better, than with in person because they don't have to travel. As a result of the pandemic, that has increased substantially to where a large number of patients now are choosing to have telehealth as their preferred means to contact with their primary care. It also adds tremendous access for patients in addition to convenience. So what the amendment that I put forward does is two things. One, it is simply a replace all of Senate Bill 238 with the language that was in House Bill 500, with the addition of a paragraph 2 Roman 5D, which deals with the consent for a minor as requested previously. it's important to understand that, that telehealth is really here to stay, in that the great majority of patients, many of the patients prefer to have a telehealth appointment. Many appointments are done specifically and only as a consultation or conversation, and a lot of appointments have very little hands-on necessarily. The other thing is that what's really remarkable to me is that even in a specialty like orthopedics, which you would imagine is fairly hands-on, examining joints and et cetera, many of those appointments and follow-up appointments can be done, and can be done very well on telehealth, particularly with given their mobility issues. The great majority also of x-rays that are done at regional hospitals are now interpreted 24/7 at DH. And so you can have your whole appointment, whether it be an x-ray and then an appointment to follow via telehealth. And the people that really benefit from this tremendously are not only the people with mental health issues, but also those with issues regarding palliative care or hospice care. That travel to and from a hospital is really not only an inconvenience, but sometimes dangerous. Post-op patients that have difficulty with mobility, oftentimes all you really need to do is check in with a telehealth appointment, look at their wound on telehealth, or talk to them over the phone and say, how you doing? And if they have no concerns, then you move on, and you can do other things that happen in an appointment that you would otherwise do in person. So for instance, you may prescribe physical therapy or occupational therapy. You may order a consult. You may order an x-ray or another study. This can all be done via conversation over telehealth. So it is a blooming, growing field in the care of patients, especially in a state like New Hampshire, which is fairly rural. And getting here, particularly in the difficult winter months, is a certain advantage and even a safety concern for many patients. So the bottom line is that this is a bill that we passed, House Bill 500, unanimously 20-0. And this bill, the amendment that I'm putting forward, is really a place all of 238 to expand the scope of practice of telehealth, but also to provide some language regarding consent for minors. So that's where we are right now.
Thank you. Other discussion? Yes, Representative Weber.
Thank you. So my understanding is that all we've done is take what we already passed and included the consent provision. Would you speak to the provision of the consent provision and just tell us what it says?
Really what it says is that you need to obtain oral or written consent from the patient, and or if the patient is a minor, from the patient's parent or guardian, unless state or federal law allows a minor to consent to treatment without the consent of a parent or guardian. So it gives clarity to consent for a minor with the state and federal statute or laws modifying as necessary.
Other discussion? Representative Leon.
Thank you, Mr. Chairman, and thank you very much, Representative Murphy, for bringing this amendment. I had actually looked at replacing those sections around prescribing with our language from House Bill 500, and I really, really appreciate you taking on the consent factor. As far as the consent goes, this is a very good step, but I think that we still have some existing problems around informed consent that'll be beyond the scope of this bill. Mm-hmm. But I think that it's very, very important that we do serious work to get appropriate definitions, guidelines, and guardrails on informed consent into the statutes, so that as we expand non-traditional medicine and we have these appropriate consents, we make sure that people are protected in this process. I guess I do see in here that it says that there's obtained consent from the patient or parent or guardian only once. Mm-hmm. My only question around that is if it's once for the entire course of things, or if you end up interacting with them on a different issue, because maybe you may be consenting with me about my sprained wrist and I squeeze it for you on camera so you know I'm not doing the long bone fracture scream. But then if we move into a different topic, I'm concerned about whether it would be a notification if it's a change in scope.
I would think, I would agree with that if in fact you're really obtaining consent to treat a particular problem that a minor has. So I think that probably is the scope. It's not like once you provide a consent to treat, that it's for every episode of care that goes forward, even and specifically, and to your point, for a different problem altogether. So this is informed consent specifically for the, in my mind, for the problem at hand.
Can I follow up to that?
Follow up.
Thank you, Mr. Chairman, and thank you for that. I know that this is under a bit of a deadline because the federal rules that allow it expire either May 11th or 13th. So if you were to write the committee report, would you be willing to discuss that the intention is that it's only for a particular scope
Yes.
and that any scope of practice would change?
Yes.
Thank you.
Other discussion? Representative McLean.
Yeah, and just a question. I mean, I like this because it takes 500 and makes it stronger. But in your experience, just common practice when it comes to consent, is that how consent is understood today?
I think it is, but I think to Representative Land's point is that it shouldn't be implied that it is for a blanket coverage when you first establish a patient-physician relationship, but that if we have a consent for the operating room, it's an operating room consent for that procedure that day, not for, if I did a total hip today, it's not for fixing their broken bone two years from now. So it is, that's my, interpretation, and I think it's always been the standard of care that any informed consent is done for the procedure and or treatment that you are rendering at that point in time.
Representative Cushman.
Thank you, Mr. Chairman. Thank you for bringing this amendment forward. I agree, it's a good step. I don't think that it quite meets where the rubber meets the road. It's not strong enough. I think you could put in your report that it's for everything on, in one encounter and one problem, but when this is implemented by private medical facilities, they're not going to have the committee report in front of them. And I'm concerned, especially because this started as a bill about mental health treatment, that we will have minors who are meeting with a psychiatrist via telemedicine and they get consent for that first meeting. And then, at the next one, the psychiatrist says, well, we should put you on these 6 medications. And now they've already gotten consent and they don't need it again. So I see kind of a hole there, and I won't be able to support this amendment.
Other discussion? Yes, Representative Shapiro.
On another issue, I would like to confirm and remind people that this still requires a yearly in-person visit.
It does. It requires first establishing a patient-physician relationship, and then subsequently at least annually thereafter. And also to remind us that this is really a bill specifically about enhancing. This is not a bill for enhancing a physician's practice. It's not for enhancing a hospital's, ability to care, ability to bill for patient care. These patients need the care regardless if they see a physician or a provider in person. What this bill really does, and if we try to get to the root of it, it's the core concept of the bill is to basically provide access to care for those people that for whom getting to the hospital is a not only difficult but also sometimes dangerous. And again, this provides just another mechanism in which we can provide increased access but also appropriate care to patients. 1,700 sounds like a lot of patients per day getting telehealth visits, but we're talking in relationship to several tens of thousands per day getting access to care. This would only be utilized from a provider's perspective when it's appropriate to see a patient via telehealth. It doesn't ease their ability to take care of a patient. They still have to document, they still have to see the patient, whether it's in person or via telehealth. It just provides an access in a means by which patients can get safe and reliable and, timely care.
Follow up.
In regard to the informed consent, and I absolutely believe that parents should consent to any kind of treatment, I would say that that's kind of a complex and fuzzy area sometimes. When I had a private practice and I was treating an adolescent, I would definitely get parental consent to do that treatment, and I would renew that consent every year. But I would not necessarily, unless it was clinically called for, I would not necessarily get consent again every time we talked about a different issue in that child's life. So I think I think the spirit of what we should aim for is that we're absolutely having the parents' permission to be doing what we're doing with a minor. But I think it's kind of a complex thing to define in writing.
Representative Nagel, did you have a question?
First of all, I'm sorry, I'm a little dazed here. Thank you very much for bringing that up. I was very concerned about the people I represent that I've talked about a million times not being included in this legislation. I have a question, I think, more than anything. So I do a lot of telemedicine for the reasons that you said. I would never, ever make a major change in my treatment plan without physically seeing the person unless it was an extraordinary circumstance. But I was kind of looking through the legislation, somewhat to the medical board rules and things like that to see if that's in statute, but I did not see it. Do you know if that exists, that there's a requirement, or are we just talking like ethics and best practice?
I'm not aware of anything written in statute that specifies exactly when and how often you have to have, consent. But I would echo and agree with your intent about informed consent, and also Representative Shapiro. I mean, for us as clinicians taking care of patients, we always, obtain consent from an adult for a procedure or from an adult for the care of their child or adolescent or their minor. And that's just the way we practice medicine. And so, that's the way I've always practiced, and I think that's the way you always practice, and we always would do that. If we ever made a major change to their medication or their treatment or procedures, I mean, you always get informed consent from the custodian of the minor.
Can I ask a follow-up? I'm sorry.
Follow-up, sure.
So one of the things that I think is a little confusing about telemedicine is sometimes there's an audio or a visual component and sometimes there's not. There's a dramatic difference between the two in terms of follow-up care. Should we be separating these two in statute also?
I'd like to respond to that. I think it is defined as both audio and visual, and I understand the concern you might have, but I also think about it from a clinical perspective. If I, as a surgeon, wanted to see the patient and I wanted to check the wound, I would then insist that they come and see me. Okay, I think there's certain ethical standards and there are safeguards, that are, dictated by the Board of Medicine and by our licensure. And so I think I wouldn't say it's at the discretion of the physician, but on the other hand, as well as I, that if I had to see the patient physically present to either examine them, check a wound, whatever it is that requires in person, I would insist on that, even if it's necessarily not the most convenient thing for the patient, but I would do that anyway. But oftentimes, many of our appointments with patients are mostly conversational. We are, how you doing? How's your range of motion? What's your pain level like right now? What do you need right now? And that can be handled. So I without further handcuffing, the clinical practice, which I think is always intending to do the right by the patient, I would never, not see a patient if I was concerned about their wound. I would actually say, you need to come in. I need to take a look at this. So I'm not sure separating them out would necessarily do anything but add further confusion to the bill.
Representative Weber.
Thank you. I've got several points to make. The first one being that we already passed every single thing that's in this bill except for the consent piece. We have had over the years discussions about telephonic versus visual communications. And I think the thing to remember about this bill is it's not relieving physicians, and I think people have touched on this, but we're not relieving physicians of any of their obligations of practice by doing this. We are simply giving them more tools. And so if a physician, God forbid, is using it inappropriately, there are disciplinary tracts of various sorts, flawed, but they're there to help with that. So what we're doing is keeping everybody's standards as they are. We have made, if we adopt this amendment, the consent marginally clearer, and yes, it is fuzzy, but it's marginally clearer if we adopt this. And otherwise, we're just giving medical professionals a tool at a time when we very much need it. And I will say, as somebody who lived with a husband with metastatic bone disease for 4 years, if I'd had to drive him from my home then in Brattleboro, Vermont, to Dartmouth Hitchcock for treatment, he would have died in year 1 because he would not have been able to take the pain of the transport. Because the hospital was 10 minutes away, we could get him there for every single treatment he needed. But on the days when he did not need a shot or an infusion, it would have been such a relief not to have had to haul him physically out to the car, haul him out of the car, haul him into the doctor's office to have a conversation. It just would have been an incredible blessing to have this in place. So I urge the adoption of the amendment. I have urged the adoption of the whole bill, and I hope that it will be concurred with and wing on its way to the governor before the deadline.
Representative Cushman?
Thank you, Mr. Chairman. Well, I agree, and I support SB 500 as it was written, because I think it was almost better to be silent on this consent and just stick with the current laws as they are. And in this amendment, having this oral or written consent, and, you know, this clause on line 27 and the other one for the nurse practitioners, we're opening it up to where consent won't be required for minors by their parent, or from their parents for minors. I would support this amendment without D, because that last sentence, for services delivered through on an ongoing basis, the practitioner need obtain consent from the patient or parent or guardian only once. We already have laws that require consent for treatment of minors, except in very specific circumstances. And I think that those are strong and they're clear. And this opens things up to a lot of nuance. Thank you.
Representative Merchant? I'm sorry.
Thank you. Help me understand, when I look at this issue of consent, how is this different using telemedicine from an in-person visit? Because if you have an in-person visit, because this doesn't deal with in-person, it deals with telemedicine. Mm-hmm. So is there a difference between what we're doing here under telemedicine versus what would happen if they came in person?
I'm not aware that there's a difference.
Thank you.
Representative Leon, and then Representative Weber.
Thank you, Mr. Chairman. I was looking at this and looking at the potential to have a Section E to schedule an in-person encounter following any major change in treatment. But I'm almost wondering if standing with our position on House Bill 500 makes more sense if the existing informed consent stands. So that is my question there, because I do like having more consent for children, but I do agree with Representative Cushman that perhaps this actually lowers the bar as opposed to going with what we already have. And without a deep dive into this consent section, I don't want to potentially dilute the protections we already have in place.
Okay. Representative Weber, and then Representative Mazur.
I just wanted to alert the committee that the consent provision was to incorporate some of the Senate's language on 238 that I think I was under the impression that everybody thought was good. But in the event that this amendment is voted down, I have another amendment that's just 500 as we passed it. So it's available to us if this amendment goes.
Thank you. Representative Missouri.
Yeah, my concern too is what others have said, is section D. Specifically, the minute this came before me, I underlined it immediately, was the, consent from patient, or parent or guardian only once. So that to me sounds like a blanket consent instead of per diagnosis consent, which diagnoses can change drastically. And so does that consent just one off, just blanket right through the whole thing? That's my big concern with that particular line. I can't vote for this with that line in there.
Thank you. Other discussion? Representative Cushman.
I would be happy to support Representative Weber's other amendment after taking a look at it. And if it is just SB 500, straightforward,
House Bill.
replacing HB. Thank you.
Okay. Other discussion? Representative Murphy?
Yes, it was brought up about, some of the safeguards and, for prescribing medications for minors or otherwise. And I just want to remind us all that there are multiple safeguards in effect already when prescribing medications. Not only the DEA requirements that we all have in our prescribing practices, we have standard of care in our DEA licensure. We have here a stipulation that have to be seen at least once a year. But I'm not sure, but we also have in the state of New Hampshire, the New Hampshire prescription drug monitoring program, which really does electronically monitor all the medications that are prescribed. And if there's any particular red flags, they will be alerted to either the provider and or the Board of Medicine. So there are a lot of safeguards in place regarding prescribing of these medications in the state.
Other discussion? Yes, Representative Merchant.
If I could follow up to the issue I raised before, if this is the same requirement for in-person versus telemedicine, why do we need it in the first place?
Other discussion? Representative Cushman? or-
I think it came up because there was language in the original bill that was concerning about consent. And so it was well-intentioned, but
Yes, Representative.
Clarification on
Representative
that
Weber.
last one. There was no concern in the original House Bill 500. And the incorporation of this consent provision came from the language of Senate Bill 238. And I just wanted to be sure that we were all clear on that.
Okay, Representative Shapiro.
Thank you. Can I suggest that we take a straw poll about which amendment? It sounds like everyone's in favor of this bill generally. And can I suggest that we just take a straw poll about which amendment people would prefer?
That sounds fine to me. All those in favor of the current, I'm sorry, go ahead.
Representative Murphy had.
Representative Murphy?
I'm not sure this will change anybody's mind or not, but I understand that the Senate has passed House Bill 500 with the amendment that's already incorporated here. So, with this amendment, with this language,
Representative Cushman.
with the consent language also,
yes.
Okay.
Okay, do we still want a straw poll?
yes.
Okay, so all those in favor of the amendment before us right now, please raise your hands. Okay, all those in favor of, all those in favor of what Representative Weber is talking about, raise your hands. Because that would be the more popular of the two, or the more support. So, okay,
Would it be sensible simply to proceed to a vote on this amendment and see?
I would say so. Yeah. Any other discussion? Seeing none, let's have a vote. I'll ask the clerk to call the roll.
Representative Leon,
No.
Which amendment?
Oh, it'd be, what's the number?
14728.
One that we have,
14728.
we only have one motion in front of us.
Motion is ought to pass on this amendment.
Representative Cushman,
No.
Representative Bill King, no. Representative Hull,
No.
Representative McLean,
No.
Representative Seth King,
No.
Representative Mazur,
No.
Representative Nagel,
Yes.
Representative Pelosi,
No.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Priest,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
No.
Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
Representative McDonald,
No.
10 to 10.
No.
So it's 10 to 10. Okay.
So the amendment fails.
No, amendment fails.
Mr. Chairman, may I move Amendment 1454H?
Sure.
And my direction to OLS was simply to incorporate our House Bill 500 into this amendment.
I've got to, I've actually got to go over to the ED&A meeting for a brief period upstairs. I'll be back shortly, and I'll turn the chair over to the vice chairman.
Thank you very much. And was that a second from Representative? No, sorry. Sorry. That's right. Yes, we do have the amendment.
Who was the second?
Sorry. Did you want to second with the amendment? Okay, yes.
Priest?
Priest, yes.
I'm assuming you're making the motion.
So,
Okay.
so I just want to give everybody a chance to read over this and make sure that they're comfortable and that it's the same as 500. Oh, I have it saved in here. Yes.
I realize it's, process question or proposal to raise with committee. I know it's executive session, so I'll offer that and then let you decide whether I can want that.
You have a process question?
Yeah.
Yes, you can ask the process question.
Thank you, Madam Chair.
Can you push the microphone, please?
For the record, my name is Matthew Hood, Government Relations at Dartmouth Health. As Representative Murphy indicated, the Senate HHS committee this morning voted to approve, I think as he said, HB 500 as it came over from the House with the consent amendment, which the chair felt strongly about to cover belt and suspenders, I guess, in that case. If the House, my question is, if the House sends something different back to the Senate, I think, do we miss the time frame to catch that
May 11th date? That's my question, Madam Chair.
Thank you, and that is a very good question. So that was a committee vote in the Senate. So they have adopted an amendment, but they haven't taken it to the floor. As co-equal bodies, if we take this amendment to the floor, we then as a whole body will vote on it. And so we will see, we're following the process through with both sides. I understand the time frame and the need, but we also want to make sure that we're making the right legislation. Representative Weber?
Thank you, Madam Chair.
The other thing is that either of these will be voted on on the floor by the full body, full Senate or full House. It will then go back to the other body, either for concurrence or for committee of conference if they differ. And at that point, the two bodies together are in control of the time frame, but it's going to be the same question either way. It's just going in different directions. If we have one House version, and if the House and the Senate pass two different versions, there is the opportunity for a committee of conference, there's the opportunity to concur and simply send it to the governor, or there's the opportunity to non-concur and let something die. And that happens every single time.
Yes, thank you, Representative. I'm raising the question purely for the time considerations, understanding that co-equal branches can approach things how they choose, and just trying to figure out the dovetailing of it if the policy is in fact favorable to both bodies.
Madam Chair, point of clarity for myself.
Representative
So this amendment, Representative Weber, you said had HB 500 language in it. Without though the amendment, we don't know what the amendment is at the moment because it just passed this morning.
Representative, I'm under the impression that it was the exact same language that we saw in the amendment introduced by Representative Murphy, and that was intended to streamline the process. However, what I'm seeing here is that this committee was, while we appreciated the idea of the informed consent, was not in favor of that amendment. So we're looking now to see if we want to state the House position of House Bill 500. And if this is something that'll be adopted by this committee. If it is, then that also sends a signal that this committee as a whole did not adopt the informed consent provision and believes that the existing law already covers this use case. I know I personally appreciate the Senate's attempt to do this. Informed consent is something that should always be improved upon. But I'm not convinced that this is an improvement, which is why I did not support that amendment. Even though, quite honestly, at first glance, I thought it was going to be fantastic. But that's why we have these sessions, so we can discuss the issues. So has anybody had a chance to look through? My internet was loading slowly. Is this the same as House Bill 500? Okay. So would you like to speak to your motion, Representative Weber?
Solely to say that it was my instruction to OLS to simply substitute House Bill 500 as adopted by the House in its entirety. So I hope people have had a chance to check and make sure that was done. I didn't because I was trusting to Representative Murphy's motion, but I hope this will be favorable.
Thank you. Is there any further discussion on this amendment? Okay.
Madam Chair.
Yes.
I was not on this committee as a member or a sub at the time, but it does look from the docket that HB 500 passed on consent, right? 20-0 out of the House and then or out of the committee and then on consent. So I think there's a very well established position for this.
Yes. Thank you very much, Representative. Yes, it did go through quite well because we see this need. I appreciate the Senate trying to expand the coverage, but I know that I'm personally not quite ready for that myself. So I guess if we're ready, we can ask the clerk to call the roll.
This is Amendment 1454H. Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Hull,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Priest,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
and Representative McDonald is not here. 19-0.
Thank you. The amendment is adopted. Is there further discussion on the bill as amended? Representative Weber?
I would move the passage of the bill as amended.
Thank you very much. Thank you very much. Is there a second? Representative Cushman? Thank you. Thank you for correcting my process. I appreciate it greatly. Is there further discussion, or shall I have the clerk call the roll? Well, once he has a chance.
Who made the motion in second, please?
The motion was made by Representative Weber and seconded by Representative Cushman.
Thank you.
Representative Land,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Hull,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel.
Yep.
Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Priest,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Lanza,
Yes.
Representative Tejas,
Yes.
and Representative McDonald, no vote. 19-0.
Is there any objection to putting this on the consent calendar?
Madam Chairman,
Yes. Representative McKay?
when you're presiding, don't you vote last?
Should I be voting last when I'm presiding?
That's a good question.
Okay.
I'm sorry about that.
Not a problem. Thank you for the correction. Okay.
That's a house rule, isn't it?
Uh,
It's custom, yeah.
And,
But if nobody, I assume if nobody here objects to it, it's not.
and
Oh, yeah, no.
So Representative Weber, I had you on the committee report on 171 and I think on 87.
I am on 171. And I am also, yes, on 187, that's correct, so I've got three.
Okay, would you like to do this one or would you like somebody else to write it? Okay, fantastic. Just didn't want to overburden you. Thank you.
A huge burden.
Copy.
I would have to check on what we're allowed to do for about discussion of what's going on in the other body. I don't think I can incorporate it into a blurb. So I think I just have to say that what we've done is we've simply taken what we believe to be the better bill, which is already the position of the House, and send it back to the Senate that way.
And that we've reaffirmed our position, perhaps. Thank you. I know that numerically 239 would be next, but Chairman McDonald needed to step out of the room. I do know that there are some moving pieces on House Bill 240, so I didn't know if we wanted to take up 240 next, to at least start discussing before we have a motion to understand the landscape. Representative Weber, would that make sense?
I think we're in the same position with either of them, but if I may speak to 240, the bill as it came to us was confusing, and I personally had a significant amount of difficulty understanding exactly what the purpose of the bill was, because as you may have remembered, I said at the time Normally, we think of a patient as being able to consent for treatment to whatever they want to consent to, providing they have informed consent. And I thought that what I was hearing was that this bill was needed because they were prohibited from doing that. And after a significant amount of back and forth, I think we have reached the conclusion that yes, they can, but more clarity would be helpful. The second thing that happened is that there were provisions added to the bill in the Senate that dealt with clinical research. And I think what emerged in talking to various people was a notion that there is a significant difference between your consent to sharing of certain sensitive information for treatment of your own condition and to uses for research, and that people might want to have a greater clarity about the differences between those two things and the opportunity to consent to them one at a time, so that you might want to consent to one, you might not want to consent to the other. I've had discussions with Mr. Hood and various other people about what that language might be, but we haven't reached the language yet. So if that's a concept that people would like to consider, that's great. The suggestion I made to the chair was that because 240 is not an early bill, was that he appoint an official subcommittee, not an informal subcommittee, so that it had actual hearing notices in the calendar, because this isn't due till June 1st. And that way we would be sure that everybody who wants a bite at the pie, not just the people that I happen to be calling, would get their say. But that is up to the chair. So that's as far as I've gotten.
Okay, thank you very much, Representative Weber. That's a really good landscape, and that's actually pretty similar from with the discussions that I've had as well. I guess seeing that it's 1:45 and that the chairman's in another committee, perhaps we want people to think about whether they'd want to participate in that official subcommittee. As far as the members of this committee go, perhaps we should break for lunch until 1 o'clock, and then we can officially open that executive.
Well, it wouldn't be an opening in executive session. If the chair chooses to appoint a subcommittee, the chair may simply do it without input from any of us.
Okay.
But I hope he would ask about interest, and I know, knowing the chair, that he would.
Oh, so that's something that we can do when we come back from lunch at 1 o'clock.
Yeah.
Does that sound good to everybody? Then with that, we will recess this executive session until 1 o'clock. Thank you.
Back from lunch and away we go. So it looks like there's two bills left that, at least for today, for us to look at. One of them has some amendments pending, and the sponsor of those amendments had to go over to the State House, so we'll wait on that a bit. So why don't we go to everyone's favorite and the long anticipated discussion on 263 Medicaid expansion. And yes, Madam.
Thank you, Mr. Chairman. Since this is such a big, wild and woolly topic as a whole, are we just going to have just a discussion about points at this point before bringing
That's
anything
fine,
formally?
sure. That's fine, sure. Kind of a groundbreaker or icebreaker, so to speak. I know there's a lot of concerns, understandably so. It's a huge issue.
Mr. Chair,
Yes, Representative Mazur.
what are we doing with 240?
That looks like it's going to be, we're going to put a subcommittee together
Okay,
and,
so we'll wait till they get back, is that the, okay,
well, we don't have to wait on that one until they get back.
oh. Okay,
But,
so are we done with that one then?
For the time being, are you interested in serving on a subcommittee for that one? Or? Okay, Representative Weber, you would like to, okay.
And I would as well.
Okay, so, and the average subcommittee is, I know it doesn't have a specific,
It can be 3 or 5, or, I mean, it can be even if we want to have it even. They're supposed to be in proportion to representation, so it probably ought to be even at this point.
okay, so Representative Leon, Representative Weber, anyone else want to be on that? We can settle it right now if we want to. Did he?
Yes, Representative Merchant wants to be on it. I wasn't sure if Representative Nagel has spoken to whether he wants to be on that.
Okay, oh, we can wait then. All right, so,
And do please remember that they're supposed to be in proportion to
oh, sure.
representation.
So we have 3 Democrats right now, so we need 3 Republicans. Representative Weber, I'm sorry. You're not a Democrat, are you?
No, I'm not. Long ago.
Oh, well, I wasn't counting him yet. I wasn't sure that he was, definitely wanted to be. All right, so yeah, we need 1 more Democrat and we need 2 more Republicans. So, okay, we can talk about that more when,
Well, if we could just have one, I mean, if we've already got 3, we'll just go to 4.
that's fine too.
I mean, I don't think it needs to be a huge committee. I'm sorry, for my purposes, what needs to happen is we simply need to have a formal subcommittee, so that notice can be put in the calendar of a subcommittee meeting, so that all of the parties who are interested in that bill can come and be heard all at the same time, so that we know that everybody's getting their say in, and we also know that it's being done in a timely fashion and not hurriedly with
Is it
sort of
your thought
email
we should
messages
try to
back
do
and
that
forth.
For this upcoming calendar or?
That's up to you, Mr. Chairman. It can be done for the upcoming calendar, or it could be done, it depends on when you want to hold our next meeting.
Well, I was thinking of continuing every Wednesday until we get our work done.
Okay.
Representative Leon.
Thank you, Mr. Chairman. I'd make a suggestion then for the subcommittee to wait until the following week, so that everybody will be able to be there and we can focus on these bills to figure out where we are, if any of the others need subcommittees or not.
Well, my suggestion would be that the subcommittee meets well before the committee meets, so that we can get whatever we need for an amendment. I mean, it can't be the same day.
So yes, I agree to that. What I was saying was the other bills that we're pushing forward, the question would be if we were going to look to schedule any of those next week to work on them, or if we'd be moving further forward.
Well, but the chair just said that we were going to meet every week until we finished our business, so I thought that answered that question.
Good.
Are you suggesting that we meet sooner than Wednesday for the subcommittee on 240?
I'm suggesting, first of all, it has to be calendared, so we have to get it into the calendar. If it's next Wednesday, I can't meet next Wednesday because I'm not going to be here next Wednesday. It could be, from my perspective, earlier in the week or later in the week, and then taken up either that week or the following week.
And that is one of the participants on that. I would be available Tuesday if we could find time frame. So maybe we can, although that, I don't know if that's too much of a sprint.
I'm not persuaded that, I think it probably, if everybody comes and speaks their mind at that subcommittee, as opposed to later on, I think we could be done. And I have made it very clear that my own position is that if we don't come to a very solid agreement that satisfies everybody, either for a smaller piece or a larger piece, that I would be willing to either retain the bill or ITL it altogether. So I think that next week is fine, and I'm just checking calendar right now.
That would be May 2nd, right?
Yes, that would be May 2nd. I'd be available after 10 o'clock that day.
I too would be available after 10 o'clock that day.
Maybe we should, we'll see about finding a space for that. Is that tentatively? Okay. Perfect, thank you. Does that sound good, Mr.?
I'm assuming that Representative Leon is going to be the first named on that subcommittee.
Yeah, I would say.
Okay.
I would say. Do we know if Representative Merchant, Representative Nagel do want to serve, or? You know, he does want to serve, right, for sure?
And I think Representative Nagel works on Tuesdays.
He does. He still sees patients on Tuesdays.
Right. And I can't do Wednesday.
Thursday's a session day.
I think maybe our next step is to see if they can find us a room for Tuesday while we see if the other members are available.
The other thing is that you could appoint a subcommittee of two, and if other people want to help out.
Well, Representative Nagel, doesn't he late in the afternoon, does he motivate? Oh, okay. Right. All right, yeah.
We can get the
subcommittee-
room booked, and then when they come back, we can flush out the membership when they come back.
But yeah, we can, Christina, we can schedule a subcommittee, right, and determine the membership later? Can we do that? All right, why don't we do that then? So, does that work?
10 o'clock.
You said after 10 o'clock, so will you be available at 10 o'clock?
Could we do it at 10:30?
Sure.
Just because I
Okay.
have a 9 o'clock meeting and I don't know how long it's going to go.
10:30 sounds wonderful to me.
So far, we have a subcommittee of two, and that may be expanding, but we'll talk to the other two when they get here. Okay. Anything else on 240? All right, let's move on to 263 then. I'll just open it up for discussion. Obviously, the bulk of the discussion, the bulk of the debate, it's focused on a sunset or no sunset, or how long a sunset. Representative Leon.
Thank you, Mr. Chairman. I recognize that this bill is almost exactly what we passed in House Bill 2, except that bill has a sunset and this one does not. The commission that is in there is exactly the same in House Bill 2, everything except for either repealing the chapter law that enables Medicaid expansion, or the 2-year sunset, which we have in House Bill 2. So there's a couple different points to discuss on this bill. One is, what's the correct sunset? Personally, as far as I'm concerned, I'm pretty sure that debate is going to happen in the House Bill 2 budget discussion about where everybody eventually settles on a sunset date. And having two moving pieces at the same time gets to be pretty complicated. So I personally like the idea of leaving the sunset discussion to the budget. There's other issues too. This bill brings a permanent Medicaid expansion that uses statute that includes sections that say until this date in 2019, the department shall. So there's lots of old language. There's other language that right now they're not able to enforce because they had sought waivers at different times. There had been a ruling on the work requirement. And this unlimited Medicaid expansion bill really brings up the question that we need to discuss what's happening with this bill what this program should actually look like, looking to update the language to make sure that it actually reflects what this state wants, and not to just go ahead and roll it forward for a very long time period without bringing up these really big and really important questions. Just as far as one goes, we've discussed with the developmental disability community how important it is to be able to work. Because when you work, you participate, you build self-worth, you have a lot of benefits that come from it. And the fact that we have the work requirement now non-enforceable and Medicaid expansion is a problem, because there are, within that, there is exemptions when medically you can't work, or there's other reasons why you can't work. But your average person should be pursuing a job and a career. And I'm worried about this whole language about your average able-bodied person should be working, when we're trying to make sure that your average person who's not quite as advantaged is also working, but it's good for all of us. So to be able to work, to hold down a job, to have something that motivates you and drives you forward. So that's just one of the many areas. I have several different amendments that deal with different aspects, but I don't want to monopolize this. I just want to make sure that we have a chance to discuss what this bill would put permanently into law with no sunset, and make sure that we're comfortable with all those provisions.
Representative Weber.
We held a very long hearing on Senate Bill 263.
2 hours and 45 minutes.
And if I counted correctly, which I may not have, 33 people actually spoke to us. And 34 people actually spoke to us, 33 in favor of the bill as it stood. And one person spoke against. The people who spoke in favor represented a hugely broad coalition of business, medical care providers, medical care recipients, people whose lives had been changed for the better by the availability of Medicaid expansion. And so to say that there are lots of problems with this bill is to say that all of those people who came and testified in favor of the bill are somehow wrong. And what I heard at the hearing was a very broad approval of something which is in existence and is working for many people. The other thing I heard is that overwhelmingly that this is a bill that allows people to get healthy enough to be able to work more, and then to be able to provide their own health care or get health care on the exchanges. It's not a forever thing. It's the middle set of people who tend to need help for a time, either because of a life crisis or because of a medical crisis. And it helps them get on their way and get back to being a productive member of society. If what you're defining productive by is holding a job, earning money and paying taxes. There are other ways of being productive, obviously. So I think that for us to say that the collective wisdom of all of the people who testified in front of us is wrong somehow, and that we need to start over again is simply not the right way to go. And I would prefer to have the committee pass the bill and pass it as is. I think really the discussion is whether it is going to be the 2-year extension in the House budget or whatever the Senate does with the Senate budget. But I would love to have this committee and the House affirm that this is a program that has changed people's lives and will change people's lives going forward, and that we embrace it.
Representative Hall, did you have your hand up?
I did. Thank you, Chairman. So I think there's a common goal for all the members on the committee of taking care of those who need help the most. And we need to be careful when we use tax dollars for people who are not permanently disabled, right? Because we're comparing taking care of someone who's permanently disabled on traditional Medicaid versus someone who ran into a life event. Life event may be something in terms of trauma to their family, something in terms of a job change, and they're in this transition. But if I understood the member from Walpole correctly, right, 33 people testified in favor, but the last number I saw was almost 100,000 people on the program. So as a percentage of those participating in the program, that 33 is relatively small. I would like to explore things that would help these people as they transition out, because unfortunately, I don't think we're seeing we don't see this as a transitory program. There's a lot of people who are staying on this program for much longer periods of time. And I think we need to craft a program that helps people as opposed to just supports people in the terms of giving them something and leaves them at that state. Jobs are a beneficial thing. That was one thing that was discussed earlier. Maybe it's a training issue. Maybe we need to make sure that they have adequate training, and getting them into the unemployment security is part of the key element to getting them back on their feet. So there are definitely things to explore.
I will say, Representative Hall, I'm glad that only 33 people came instead of the 100,000. Representative Nutter Upham.
All right, I might be a little off base here, but I know lots of people with college degrees who have jobs, but their jobs do not hit full time, and it's because companies can't afford to pay the insurance. So plenty of people who are well-trained, educated, and whatever are kept under the 33 hours a week, whatever that would apply to full time, who don't have insurance. So, and also someone who gets on, if we authorize this bill, this doesn't mean that I feel an undertone here, that we're authorizing everyone who's on it now to be on it the rest of their lives. All of these programs are income-based and vetted either every 1 year or every 2 years. If Mr. Lippman was here, I would ask him. So I met the hairdresser last week, and she, working business, whatever, husband in the trades, they can't afford insurance for them and pay for all the other things they need. They have insurance for their children, and then the other hairdresser binked around the corner because we were talking about pet insurance. So both of them have pet insurances for their pets, but they can't afford it for themselves. So I think that to bring up this argument every 2 years, to bring, when I first came on the legislature 5 years ago, we were discussing the work requirement for this, which was cruel and ungainly for many people in New Hampshire. And when they tried to, anyway, so I think we should pass this as is. And nobody wants people to be on, as some of you are kind of hinting at, like free government sponsored healthcare forever. Most people, as a psychotherapist, most people are happiest when they're working, when they have a purpose in life, and when they're self-sufficient. And this kind of a program gives people a leg, a foot, a knee, an arm up to be able to get there. And I think we should pass it.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. I would agree wholeheartedly with what a few people said about the importance of work. Certainly for myself, work has been an incredibly important and fulfilling part of my life, socially, having a purpose, earning money, feeling in all ways. And I would encourage, it makes me really sad when I hear young people talking about work as just something you gotta do. I will say that I personally put in bills to repeal the work requirement in the current authorization because I saw it as a problem, that it was there, but it wasn't it wasn't implemented, it wasn't in effect. But those bills were defeated because people who were interested in it in the first place wanted to keep it in. The reason it was never implemented was because of court cases where first in Kentucky and then here in New Hampshire and one other state, which I can't remember, where it was ruled by federal judges that Medicaid was a health insurance program, not a work training program or a character building program. So that the amount of work that we were requiring did not fit with I guess what the courts considered constitutional. I want to just throw into the conversation here that 70% of the people on Medicaid work, either part-time or full-time. And I do believe it, I think when we talk about Medicaid in this committee, I think some people speak about it as medical coverage, medical care for people who can't afford medical care first. Some people speak about it as something that creates dependency first. I'm somebody who agrees that potentially it can create dependency, and that's a problem. But for me, that's way down the list of what it does. For me, the fact that it provides medical care, that it keeps people healthy, that it gives them the opportunity to go out and work, it gives them the opportunity to be full members of society, that comes way before the fact that it does create dependency. And I've been looking into the fact about this issue of dependency because I think it's something that we struggle with as a committee and that I want to do something about. And so the way this is referred to is the benefits cliff. What keeps people from going off state benefits or federal benefits, and the fact that frequently what people are going to lose if they work more hours or work at higher pay is so much greater than what they will gain. And that's a problem. And I didn't know this, but there's actually a committee within DHHS that has been created just to deal with the benefits cliff and what we can change in not only with Medicaid, but all of the different kinds of Medicaid, all of the different kinds of benefits, food stamps, TANF, all those things. What we can do to make policy changes that would encourage people to move on with their lives, either by getting education, by getting higher paying jobs, by getting jobs if they don't have jobs, instead of being reluctant to do that because they're going to lose out. So I think that is an important issue. And I think it is something that's, I don't know to what degree it's being addressed, but it's a recognized issue that is being addressed, which I would think that maybe we as a committee in the future can play a part in. But I think this bill, Medicaid expansion, is not going to address that. It's not going to fix all the problems with dependency, with poverty. When you think about it, poverty is one of the few issues that we've seemed to have made almost no progress with. We've made all kinds of scientific advances. We've made advances where, people have all kinds of material things like TVs and cell phones, poor people and wealthy people. But the number of people who live in poverty, who have trouble feeding themselves and keeping themselves sheltered, has not really changed at all. And I think that maybe we can have an effect on that if we work on this benefits cliff. But I think in terms of this bill, I'm rambling on a little bit. I can't speak as well as Senator Bradley, who I think spoke so eloquently about all the reasons why this has been a tremendous success, why even if it's reauthorized permanently, there are guardrails in the bill to protect us from all of a sudden having to pay a greater share of the expense for it. I think it's just been I just think it's been a success. It hasn't solved all of society's problems. It hasn't changed our, some of the basic dilemmas with healthcare, but I think it's been a tremendous success in keeping people insured, keeping providers from having to continually give out reimbursed care, and making sure that we have greater public health. And so I will definitely vote to vote for reauthorizing it permanently.
Thank you. Representative Leon?
Thank you, Mr. Chairman. I wanted to address one small thing that I said that I think has been misinterpreted. I'm in speaking about permanent or continuing Medicaid expansion. I wasn't talking about that for the individuals, but I was talking about this relic of law that we put into place in 2019 that is already outdated, continuing to be that vehicle as people hopefully use Medicaid expansion as a waypoint, not a destination, as they get to other points in their life while we support people through this process. One of the reasons why I was perfectly happy putting Medicaid expansion into the budget with the 2-year sunset was because there are a lot of people that I speak to that have Medicaid, and they have serious problems with the program, the way that they're accessing it, other ones as well. There are a lot of challenges, even for people who are using Medicaid right now. There's problems for providers who are providing services that are reimbursed by Medicaid. And the idea of just having a relic stay in statute forever. Representative Shapiro, I really applaud your effort to try and remove that work requirement because the courts had voted against it. But this piecemeal approach to addressing it doesn't really seem to work because it's all together in one basket. And it's a matter of then looking at which apples and which oranges are in this basket as we move forward. And that's one of the reasons I see value to having a sunset. I don't want to monopolize the conversation. I just wanted to make sure that everybody understands that I do know Medicaid expansion is supposed to be a waypoint and not a destination.
Representative McLean?
Thank you, Mr. Chair. I think everybody on this committee understands that we have to renew the Medicaid expansion because those things that used to exist aren't there anymore. And so to not renew the Medicaid expansion at this point would leave a lot of people out in the cold. I think the concern is just with the perpetual renewal. One of the things, if we look at the Affordable Care Act came into play over a decade ago, and there were many different pieces in the Affordable Care Act that were supposed to work, and we're supposed to have price transparency, the exchanges, healthcare costs were going to come down. We really didn't see a lot of that. The one thing, at least on the surface, that did appear to work was the Medicaid expansion. And I think in many ways, because of that, Medicaid expansion became the victim of its own success. And we saw that a lot in this committee. This is my first term on this committee, but we saw bill after bill after bill of let's add this group to Medicaid, let's add this group to Medicaid, because the perception is that this is the component of it that's actually delivering the goods. But, I wasn't here for the public hearing. I was off doing Shingo training. And when I was off doing training, one of the folks on my Shingo team was a pediatrician from Connecticut, Dr. Elliot Melendez. So he's the chief of pediatric critical care in Connecticut Children's Hospital. So I said, how you making out in Connecticut? How are things going? And he said, boys, he says, Medicaid is killing us. He said, now, we are different than you in New Hampshire. I mean, I'm in Hartford, Connecticut Children's in Hartford. So we're 60% urban, but you can imagine with the reimbursement rates that we get on medical care, on Medicaid, we're just hanging on financially by our fingernails. And so I think in many ways, he may be a harbinger for what we may see here down the road. We are not Connecticut. We are not an urban environment like they are. But we do have 250,000 people in this state on Medicaid, and that number is growing. That's almost 1 in 5 people. So I really do have concerns about the long-term financial viability and a long-term effect on our hospitals if we just let this thing go without a revisit. And the other thing, though, putting the financials aside, Representative Shapiro, to kind of talk about what you're talking about, which is the benefits cliff. I think the benefits cliff is real. When I first came to New Hampshire over 20 years ago, I came to Nashua and I lived in Clock Tower Place. You may know what Clock Tower Place is. Now this is a wonderful place. It's high end, it's a converted mill, loft apartments, great. But all of my neighbors were on social assistance, you know, some Section 8 housing, they're on Medicaid, et cetera, and so on. And these were good people. These were not lazy people staying home, playing video games. These were good people, and these were my friends. And, you know, one of them, lady right next door, Myrna, she had a job offer at a doctor's office. But she says, Mark, you know, I don't know what to do. She says, if I take this job, then I'm going to lose a lot of my housing support, and I'm going to lose the coverage for my kids. And she said, you know, and instead of having you as my neighbor, I'm going to be living down in the trees, you know, Ash Street, Pine Street, et cetera, and so on. And so she made the decision ultimately not to go forward, and she wanted that job so bad, you know. And so she's back, she's working under the table. Who am I to judge her? Is she a bad person? I don't think she's a bad person. She was a great neighbor, she was a wonderful lady, and she was an excellent mom to those kids. So I don't judge her, but I do judge the system that kept her from realizing her full potential. And so what we have in this bill to address that is a commission. And this commission is going to meet and do a report out once a year. And you mentioned as well something that I was unaware of within DHHS. But I really think that the commission is woefully inadequate. You need to have something that is looking at this very actively, and that just hasn't been done yet. So I would be much more interested to, you know, see what that is going to do, see what DHHS is coming forward in some of these areas, understanding that, and then, you know, leveraging that at some point in the future to a permanent authorization. But the real thing for me is what's going to push that, I think, is the stick. I mean, we're all good people here in this room, and once this is made permanent, we've got opioid crisis, we've got a housing crisis, we've got a homeless crisis, we've got a mental health crisis. I see us pivoting, okay, Medicaid expansion, that's dealt with for now, and the stick isn't there anymore. And so we're focused off on these other issues, not because we don't care, but there's just a lot going on. I think the stick needs to be maintained so that it's going to force a revisit. And that's why I think, I don't know what the nature of that final extension is going to look like. As Representative Leon said, is it 2 years, 4 years, whatever? But I don't think we should be going for a permanent extension at this time. Thank you, Mr. Chair.
Representative Shapiro.
Yes, I would say that Medicaid expansion, whether it's for 2 years or 6 years, which would allow for more successful procurement of managed care contracts, or permanent, is not going to solve some of the problems that you talked about, both in Medicaid, in terms of Medicaid rates, although our new budget, the House budget, does have some pretty extensive Medicaid rate increases, or the problem with the benefit cliffs, or just how we address poverty and motivation in general in our society. I don't mean by any means to say that this bill is going to solve those problems. We have a lot of deep societal problems that we have to continue to work on. I would say that in terms of providers, when I had a contract with the different Medicaid managed care companies, Medicaid was among the lowest payers for providing psychotherapy. And it was a problem. It was quite low. And I think it's one of the things that results in problems with workforce shortage. And I'm sure it's a problem with doctors of all kinds and hospitals taking Medicaid insurance. But consider what the alternative is, which is that they're not getting reimbursed at all for that care, and that they are providing that care as unreimbursed care. So I think that is why we've seen the provider communities come in and say, this is a very important thing for our future security.
Representative Nagel, and then over here.
I think I could talk all day on this one.
Don't do that.
A couple of years ago, the American Bar Association, the American Medical Association sat down and they came up with, looking at ethical issues for doctors and lawyers, and came to this conclusion that we had a responsibility to care for the people in need. So they made a joint recommendation that people that were either in the bar or the AMA were supposed to give about 10% of their care to the poor. That was great. And then comes Medicaid, and as you know, Medicaid was actually founded because the healthcare market was not caring for the poor and the disabled, and it was a strategy because they were being cherry-picked out of insurers to cover them. So that's why Medicaid was formed initially. And I remember talking to my dad when I was young, and he was an anesthesiologist, and he basically came to the conclusion that it costs, we always forget that the only number in business that matters is net revenue. It's not gross revenue, it's net revenue. It's your gross revenue minus cost. But he said that, he goes, you know what? He goes, we don't even bill Medicaid, and we just do it for free. And he goes, why is that? Because he said, because it costs us more to bill Medicaid than we get back. So he says, we might as well just do it for free and satisfy our obligation. I think one of the biggest sins in healthcare in this country was the death of private practice. I think that a lot of the issues that we're talking about now, like burnout and all these other things, are because doctors have absolutely no control of their environments anymore. And I talk to hospitalists and people at hospitals, and they think Medicaid expansion is wonderful. It's great. It's wonderful. I said, in private practice, it's horrible. I mean, we've gone from a system that we used to be able to do what we thought was best for our patients. And granted, that's unlimited control, and a blank check's not a good thing. But at the same time, we've gone to the exact opposite extreme. And what I can deal with commercial insurers is that I've got people that I can deal with, that I can interact, who question what I'm doing, that I can talk to, and then do what I think I need to do. With Medicaid expansion, that is totally not true. The people that make the decisions for me are not experts in my field. They will make unreasonable demands of my time for very little money in return. They will, after they've denied my request to do a procedure, they use evidence-based that's incredibly questionable at best, and there doesn't seem to be enough transparency about that. I talked to our practice manager. She said Medicaid expansion is killing us. And we also have to realize that we're talking about two separate things. We're talking about, Medicaid for a new group of patients that were people that were insurable before that are not now, and then we're talking about the poor and disabled. They're two totally different groups of people. But as far as I'm concerned, if I'm a private practitioner, I'm one of the last private practitioners left in this state, and to me, I would never work for somebody else. And this is making my job harder and harder and harder to do. And the other thing is the cost of me employing people to deal with their denials, their demands, when they're not paying me enough in return to make it worthwhile. That's a real problem. And I think that as we go forward with our healthcare decisions, especially for people with complex disabilities, I look at Medicaid expansion as a necessary evil and a Band-Aid on a broken system. the reason why I think that there should be limits 10, 20 years or whatever is that if you don't give people a limit, they will go on forever. And I just don't think this program can continue to grow unbridled, and it needs to have some oversight and some limit. That's enough for me.
Representative Murphy.
Thank you, Mr. Chairman. I think anybody that's practicing medicine, like Dr. Nagel, Representative Nagel has done, could speak forever on this, and we should never do that. But having said that, I was never in private practice. I've always been involved in a tertiary care medical center where we took all comers. We were salaried, we took all comers, and that included probably 2/3 of our book of business was federal reimbursement. So you had Medicare, which people would say is pretty good. That was after sequestration, that was cost minus 1%, and Medicaid, which is about 50 cents on the dollar. So yes, the reimbursement is not good, but as others have said, some reimbursement's better than none, because when you have a razor-thin margin of 1% in a hospital or a negative margin, any funds coming in to support the organization and other patients that need that organization is beneficial. But I wanted to speak to something else, and I appreciate the permanency issue of this, because you're really speaking to the fact that if this is a broken system, I would always say we have really good health care. We have which I would rank as A+ in many circumstances. There are many great clinicians that want to take good care of you. Administratively, across the country and the state and the region, I'd give us probably a good D- as far as operational, running of the show. I get that, and I've lived through it. On the other hand, this is really a federal, you got to remember what Medicaid is. It's a federal program. I know it's shared by the state. Medicare is 100% federal. This is a shared program, it's federal. So when I look at the permanency of this, I'm thinking it's permanent until the federal government can come up with a better, healthcare program for the country and or the citizens in the country. So to me, it's a federal program in many ways, and until it becomes changed in some way by the federal government, I would vote for permanency only because once the federal government changes it, gets rid of it, modifies it, we'll basically be out of it. But I would also speak to one other thing that you see regularly with these patients is the psychological benefit. We can speak about how it's good for hospital reimbursement to have something versus nothing. We can speak about the job force, and if you have a job, you have healthcare, you can get a job and be employed. I understand all that. There's a lot of arguments in favor of it, but I would argue about also the psychological impact of having insurance. And so you would oftentimes see patients come in with delayed care for whatever. It could be a large mass. It could be, their hypertension. We've seen because of COVID, you don't have access and have not had access appropriately for a lot of patients because they're afraid to go in there. But when a patient gets Medicaid, they don't understand that you're getting paid 50 cents on the dollar as a provider. They just don't get that. They just know that they are proud to have healthcare insurance. And they come through that door thinking that they're going to be treated as everybody else, and they are. And so psychologically, for many of these patients, it's a real advantage to have health insurance because they really feel like, I am now contributing, I have healthcare insurance, I'm paying you for the service you give me. And, and they're very happy and proud of that. But the other part of it, the derivative benefit of that, is that we are seeing patients that have insurance when they need to be seen. So if you don't have health insurance, you're not going to get your routine colonoscopy. You're not going to get your routine mammogram. You're not going to get your routine blood studies for whatever else you're looking to take care of, your hypertension meds. So these patients psychologically feel a tremendous benefit having Medicaid. And as a result of that, they are coming in to see you. They feel like they're contributing, and they are to some degree, but they are also getting good care in a timely manner, which when you think about it down the road, if you take care of a problem now, it costs you $10. You take care of a problem that's missed down the road, it's going to cost thousands of dollars. So ultimately, we're going to lose out when we don't support having health care for all. Is it a broken system? I don't disagree with you on that. Should it be permanent? Not permanent in the sense that you're talking about, but permanent in the sense that as long as the feds keep this program going, we should be part of it as well. And when they change it, we can then change it at that point in time. So I would clearly vote in favor of this for a lot of reasons that go well beyond what I just said, which I took too much time anyway. So thank you.
Representative Cushman, did you have your hand up?
Yes, thank you, Mr. Chairman. I also could speak all day about this, so I'll really try
Please don't
to
do that.
limit myself. I really have to agree with a lot of what Representative Nagel said. I see a lot of, we've had the discussion in here about freeing up the healthcare system in New Hampshire, and I see that dependence on a Medicaid, largely Medicaid-based system, a part of the system being a huge piece of the pie that makes up the payer mix being Medicaid, as on the one hand, the reason that the hospitals say that we can't free up the system, and then, on the other hand, sorry, I lost my train of thought. The issue is, it's putting pressure on the system, but they say that we need it. And at the same time, it's limiting what's available. So to your point, we can't have nonprofit hospitals here because you have to accept all payments, which means Medicaid. We can't have, the Cancer Centers of America come here. It's putting a block on innovation. You say that the care here is great, sure. There are excellent hospitals in this state and excellent and smart and talented physicians. But at the end of it all, not everyone wants that kind of care that Medicaid reimburses. And so when you're making it so a portion of the population, they will, you're expecting that a big chunk of your patients will only be able to receive a certain kind of care. You're not incentivized to branch out. The other issue is the work thing. I think we're incentivizing people to not work in more than one way, not only because there's no work requirement on this, but we're actually, with this program, subsidizing businesses where they would otherwise provide for their employees. And I think that's why a lot of businesses support this. It's a subsidy. People like free things. They like not having to have that responsibility. Is there a reason that businesses can't afford the insurance for people? Well, if are there regulations in the way that make insurance costly? Let's get rid of them. We need to be making this more. We need to be opening up the system more and getting to the root cause. Why is healthcare, first of all, not affordable? And instead of relying on insurance to make it affordable and give that peace of mind just because you have a card in your wallet, people should feel good that they can get health care and it can be affordable with or without insurance. So I just see that there's huge systemic issues that this doesn't resolve, and it just kicks the can down the road, and making it permanent is a huge mistake because it's, if anything, we have a very big workforce shortage. And if we're just, it used to be that you'd get a good job to get insurance. You'd be like, I have to have a job because I need to have insurance to cover my family. And now it's different. So I just see a big mix of things playing into this, and it's not sustainable on the federal level with the debt and everything else. The budget office saying that, well, we need to decrease the rolls and we need to increase the share to the state. And that's good that that's in there, that, we would sever this program. But would we really? That would be devastating to a lot of people to just stop it immediately. Something would have to be done for all those people. You can't, it wouldn't be like instant. So yeah, it's just a huge overarching problem with this. And there are specific things in here that I have a bunch of amendments to kind of trim some of the issues that I find in it. Are people actually utilizing it? Are they on it and not actually going to the doctor? Because if they are, we're paying the MCOs however much money per day to administer a certain number of people who are on it, but then they're not even using it. I don't know. We shouldn't be paying administration on accounts that aren't active. You know what I mean? there's the other issue of, yeah, that's all I have for now. I'll probably have more comments later.
Thank you. Representative Weber.
Okay, I'm trying to think of things that haven't come up first. And the first thing that hasn't come up is if we leave things as they are in the budget, in the House budget, a 2-year extension is not enough for competitive bidding on contracts. So that was one of the issues that came up with respect to the shorter time periods. And so at a minimum, we need to have a longer scope. Then we get to the question of, nothing sharpens the mind like having a hard deadline and having to do something. And I'm so glad we closed the Sununu Center 17 years ago, or whenever it was that we had the first hard deadline, because we've had plenty of hard deadlines, and the hard deadlines have been in statute, and every single time we've run up against the hard deadline, and the problem hasn't been solved, so we've extended on an emergency basis. And I realize that that's comparing apples to oranges, but the stick doesn't always work, is my point here. To blame the existence of Medicaid for the lack of Cancer Centers of America or for-profit hospitals in this state is just a disconnect. Plenty of states have Medicare, Medicaid, and Medicaid expansion, and if I said Medicare before, I'm sorry about that because it's a big bug of mine, and my apologies. But if we blame the existence of Medicaid for the absence of these hospitals, there are states where Medicaid expansion is in place, and so are Cancer Centers of America. They're two separate things, and the reason we don't have for-profit hospitals is because we voted it down when it's come up. I think that one of the two really, one more point I wanted to make was the Commission on Aging, which I actually set, noting that in particular for people of about 55 years and older who are not yet Medicare eligible, if they lose a job, there's a huge gap for them. In terms of how are they going to get coverage at a time when they are more likely to need coverage, as opposed to the 20-somethings who are less likely to need or use coverage. I did want to just refute the point about, not all 100,000 people who were on Medicaid expansion came to talk to us, but the people who did come to talk to us were a broad spectrum of people like the Business and Industry Association. And just saying that business ought to offer health care for everybody, I love that as a notion, but the fact is that 5 years ago, we didn't have expanded Medicaid and business was not covering these people, and these particular group were not getting medical care. And in particular, and this is the absolute bottom line for me, they were not getting the preventive care that they need to keep them out of the more expensive, uncompensated care that is yet another problem. So the preventive care aspect is really the one that does it for me.
Thank you. Representative Hall, did you have a hand up earlier?
I did. I come at this having sat for the most part for the last 4 months on Division 3 in Finance, discussing why expanded Medicaid ended up in.
Your microphone went off.
Thank you. Sorry. I come at this having sat on Division 3 in Finance, the division that covers HHS or DHHS. We spent a lot of time discussing adding expanded Medicaid into the budget, the discussion of a 2-year versus a 4-year versus an unlimited sunset. To the point about you can't get contracts renewed, you're right. There in a 2-year extension, right? There is no easy way to put that out for bid but there is an easy way to turn around and do an extension to an existing contract. So I don't know that that's a non-starter. I do think if this program were to continue beyond that, right, a longer time period is what you'd need to put it out to the MCOs. Regarding the for-profit hospitals and cancer centers and other alternate types of treatment, and this is at some level to what Dr. Nagel or Representative Nagel mentioned, we should be encouraging alternate solutions for people who want to run private practices, for hospitals that want to start up. Unfortunately, current statutes prohibit starting another hospital within Manchester that is a for-profit hospital or is a cancer treatment center or something that's a specialty for pick discipline of choice, I guess. So maybe one of the things we need to do in terms of tweaking the program is to start to allow additional competition into the system for those who want to expand that. As a general rule, we get what we reward. If we reward people to be on the program and we encourage that by giving them benefits, it will drive people into the system. We saw a huge uptick during the COVID crisis because we removed some of the barriers to entry into the program, and in a very short period of time, it almost doubled in size. What may be a better thing is to figure out how to incentivize people so there isn't a step function. I understand the issues of step functions as an engineer, so that they don't face if I work an extra hour or I change jobs, I lose my health care. That's a real problem, and we've encouraged that problem by the statutes that we've set up. To the member from Walpole, right? Preventative care is a much better place to put money than it is in reaction to health issues that have been delayed. So all of those weigh into it, but just pushing the program forward and another 2 years, 4 years, 5 years, 6 years, I've heard all sorts of numbers, unlimited, doesn't solve the core issues with the problem. And I mean, I have amendments we can introduce today if we're going to come back, bring those back, but I believe all of these elements need to be discussed in the program.
I saw Representative Merchant with his hand.
Thank you, Madam Chair. It's interesting to listen to the conversation. What I'm hearing is three fundamental things going on all at the same time. One is we have a social problem, we have an economic problem, we have a systems problem. We're not going to solve the social problem with this bill. We're not going to solve the system problem with this bill. We have fragmented care, fragmented coverage, lack of standards, lack of portability. Your health insurance, unfortunately, a lot of times is tied to your job, and it shouldn't be that way. But that's another societal issue. But we do also have something called economics. One of the things that caught my attention was when Senator Bradley was here, the impact it's had in lowering healthcare premiums for the employers. So the economic side of the equation has really caught my attention. As far as the MCOs, to Representative Foltz, you're absolutely right. If I was a business owner and trying to make a bid on a contract, and I don't have any assurance or even the intent of the legislative body to have at least a 5-year horizon, why would I bid on a contract? If we don't have people bidding on the contracts, the intent to us financially will be significant. So therefore, at the minimum, we have to have a 5-year horizon. In reality, Representative Weber said, Representative Weber, the word permanent around here is a misnomer. I learned a long time ago in my first term in the House, permanent is 2 years, because any subsequent legislative body can change whatever the prior ones do. So the word permanent really is not permanent. It's only telegraphing, if you will, to the marketplace, our intent is to make this at least long-term to allow for those who are out there, the MCOs, to sharpen their pencils and bring it back to us in a financial way. It's not going to go away, but if you want to be sure we have the best contracts on the table, I think it's in front of us to ensure that we telegraph to the marketplace the intent of this legislative body to make it for at least 5 years. I'd like to see it for 10 years. But that's kind of where I'm coming from. And number two, the workforce. We keep forgetting about the fact that when people are healthy and get their care taken care of, they contribute to the workforce. I've heard time and time again, we have a workforce crisis. If we can find ways to get people back into the workforce and help us become more productive, that drives the engine, which drives our economy. So for all those reasons, we can't solve the social problems. I'd like to. We can't solve the systems problem, but we can definitely solve the economic ones. Thank you.
Representative Shapiro and then Representative Nagel.
I just want to comment on this idea that because we have expanded Medicaid, that people, since we have it, it's an incentive to go on expanded Medicaid or Medicaid. And then since it's difficult to work and get the same benefits, that people don't go off of it. And I'm not saying that's never a problem, but I think the previous speaker, prior to the previous speaker, referred to the ballooning of the number of people on expanded Medicaid because they eased the eligibility standards to get on Medicaid. And I think that's not accurate. The federal government made a rule that nobody could expire for Medicaid, and therefore the numbers, and there were a lot of people laid off in the beginning of COVID. So all those people, even if they went back to work, even if they were earning enough money to no longer, even if they didn't fill out the paperwork to get renewed, by federal law couldn't be expired. So the number did go up from, sure Mr. Lippman knows, but something like from 60,000 or 55,000 to 90,000. That's true. And that's being addressed right now. And the number will go back down. And so it's not because people saw an opportunity to go on the dole and they went on the dole. It was a federal ruling that we had no control over. So there were temporarily more people on expanded Medicaid.
Representative Nagel.
Make one observation that we should really be proud of. I looked at Medicaid participation rates, Medicaid, did I say Medicare? Medicaid in the United States, and actually New Hampshire is number one. We have about an 87% Medicaid expansion rate, which is, Medicaid participation rate, which is pretty amazing. With that said, I think the reason why I would like to see a 10-year thing or whatever is this. Medicaid, especially managed Medicaid, really unnecessarily increases our costs. In getting, Representative Murphy, what I'm kind of getting back to is a lot of the Medicaid patients I see, I know they're going to cost more than I get. So you know what I do? I just don't even charge Medicaid. I don't even bother. It's not worth my time, energy, or hassle. And I just don't think it should be that way. But I do think there's some very simple fixes that maybe this commission can do to improve the way that they interact with us as doctors, as all the commercial insurers do. They can use them as role models, and they can decrease our unnecessary cost and make this project more viable. But I did want to point out one other thing. These are two absolutely wonderful documents that I think I talked to people. One year is the New Hampshire 10-year mental health plan, and the other one's the Governor's Commission on Alcohol and Other Drugs. And they're really beautiful documents, like Representative, I almost call you doctor again. Representative Murch and I have basically fixed the entire healthcare system for people with chronic pain. We did that today while you were doing whatever you were doing. So, but basically what we did was we outlined a system, and that's what these two things do. And prevention's a huge element in this, and that's important. But then they come to the conclusion is that their primary payer mix is Medicaid. And with Medicaid, they cannot cover their costs and they cannot do whatever they need to do. So the critical thing is, yeah, Medicaid needs to be an important part of what we do going forward, but we do need to accept that at some point is too much, that our systems will not survive, our healthcare providers will not survive if the payer mix goes over a certain percentage. And we really need to understand that as we go forward and not just talk about extensions and things like that, but also talk about limits. There, I'm done.
Representative McLean.
Thank you, Madam Chair. So I think, Representative Merchant, you are correct. What is permanent? I mean, permanent may be just the next legislature, but if we look at history, expansion was brought in 2014 for 2 years. Nobody talked about it until the 2 years. And then it was extended again until 2018 for 2 years. Nobody talked about it again for 2 years. Then we brought it in 2018 for 5 years, and it went silent. The debate went silent until the 5 years. So based on history, I understand that permanence is relative within a legislature, but based on history, the discussion flares up at those terminating points. And so I think everything that Representative Murphy said is correct. There's value in having some compensation versus nothing. There's value in understanding that I have insurance so that, I can go in and not avoid care, all those things, and the reduced costs to the employees that you talked about. There's value in all these things. But, again, we're supposed to be looking at the healthcare as a whole mosaic. And if you heard the comment from Representative Nutter Upham, she's talking about her hair stylists. These are working people, and they said, but they need Medicaid because the exchanges just aren't working for them. And realistically, long term, we need to have that working. And I know in this committee, we heard a whole bunch of testimony and as part of orientation on Medicaid. I didn't really hear anything about how the exchanges work. There's a lot of siloing, I think, going on with respect to, I don't know if the Commerce Committee really understands a lot about the Medicaid part. We certainly don't understand a lot about the exchanges, but all of these discussions have to happen. And I think, we need to understand what these fixes are before we can go forward and say, yeah, this is it. And so I understand your comment about permanence, but for me, history tells a lot about what the permanence is going to be. And if we extend this thing indefinitely, as I said, we're going to move on to other things, is my fear. And so I think it's really time to hold back on the permanent for now. I still believe that. Thank you, Madam Chair.
Representative Seth King.
Thank you, Madam Chair. I wasn't originally going to say anything because you guys already know how I feel about all this stuff, but I'll just make a few points that I've come up with by listening to everybody. Even the U.S. military budget isn't permanent. Every couple of years, they have to go back and get a renewal. So if they have to get a renewal every 2 years, I think so should this. And to address Representative Merchant's point about permanency, you're right that we can't bind a future governing body, but there's a caveat, and that is in order to end this program in the future, it would take the agreement of the House, the Senate, and the governor. It would take all three bodies to agree to end it or even change it. Whereas if we do it piecemeal, then if there is a problem with it, it would incentivize those bodies to work together and make the changes. Or if one body couldn't come into agreement, the program ends. So that's how the permanency does make a difference when it comes to that. It requires all agreements all the time, whereas if it's not permanent, anyways, I already explained that. If the entitlement is permanent, people will internalize that and they will act accordingly. If there's an entitlement that they think might go away, they're going to think to themselves, well, I can't get too comfortable because it could go away, so I need to take care of myself. But once it becomes permanent, people respond to incentives, and they'll think to themselves, oh, I got it made. I don't need to work too hard to become self-sufficient. And then a question I have is, what percentage of people would be too many people to have on Medicaid? Can anybody answer that for me? And will it permanently in expanding the Medicaid, will that increase the number of people on the Medicaid? And then a couple last points, and that is to address another thing Representative Merchant said. We could fix the economic problem of workforce shortage really quickly if we got rid of all of the entitlements, because you would find people coming out of the work all of a sudden willing and able to work. I guarantee it. And then lastly, people are always talking about how hard it is to live. And I think that if you are a net taxpayer, it is becoming increasingly hard to live. But when I look around and I see obesity epidemics and drug abuse problems, I'm thinking to myself, life has become too easy. it's too easy if we can sit around with all of this leisure time, and even the poor people I know have expensive cell phones and TVs and cars and leisure time. I'm thinking to myself, it's way too easy. Get these people back to work, get them off the drugs, stop them from sitting on the couch and eating themselves to death. I don't think what we need is more entitlements. I think we need to get rid of all that stuff, and you will automatically see people become self-sufficient. I promise. Thank you.
Representative Tellez, you had your hand up?
Yeah, hi. Thank you. There's been a lot shared here, and I don't have a lot of, as much off the top of my head as I did when I worked at the Department of Health and Human Services. But I don't really know people who are sitting around and that's why they're obese, right? We have issues with food security, with the quality of food that's available, that's affordable, that they're busy working 2 jobs and so they don't have time to go for a walk, or the neighborhood they live in is not walkable for a variety of reasons. And so we're talking about a lot of complexity, and I appreciate that someone broke out. There's many, many problems that we're, thinking this one bill is going to fix, and that's not realistic. So you'll recall the reason we had the Affordable Care Act in the first place was because insurance, being one of the most profitable industries in the country, was making it so that employers couldn't afford to cover their workers anymore, and people who worked couldn't afford to uptake insurance that was offered to them. And these are people who work, often more than one job. And so I think that I agree with the comment that was made that a lot of people who represent a lot of the 100,000 people who are covered came and spoke before this body and provided a lot of information about how this has really helped New Hampshire. We had an opioid crisis. We were embarrassingly #1 in the country or #2 in the country for opioid deaths. Like, that was horrible. And Medicaid expansion provided behavioral health coverage in a way that had not been provided previously. It's allowed people to at least have a minimum assurance to be able to get care when they need it. Hopefully, yes, there's issues with getting in, but hopefully have some ability to take care of their health so they can work. People want to work. I've always worked in places where people struggle. They want to work. They need to be able to get care if they need it, and not be straddled with, as we remember previously, also being bankrupted by health bills, which is also another significant problem. And so I just want to go ahead and echo that I agree that there's been a lot of good thinking and information provided, as well as data provided about how this has benefited New Hampshire. It's made us have a stronger economy. It's provided for a stronger workforce, and taking it away will just make things worse and not better. And agree that you can't contract out this issue of trying to issue contracts for, whoever will be the vendors. It just is impossible if we don't at least have a reasonable time horizon.
Thank you. Representative Merchant.
Thank you, Chair. The answer to Representative King's comment, how many people on Medicaid is too many? I'd say 1, because what that means is as a society, we're not providing them the opportunity to do it themselves, which means they're probably not employed appropriately. They're probably working what I call corporate welfare, working for companies that pay them a minimum wage, and therefore we're subsidizing that minimum wage, which is what I call corporate welfare. And also would remind people, in every single barrel, whatever we're looking at, there's always going to be 5 or 10% of those people in that barrel that don't belong there. Rotten apples. However, and I'm not going to take the whole barrel and throw it out because there's 5 or 10% in there that are rotten just because I want to get rid of the 5 or 10%. There's 90% of the people, probably 95% of the people that don't really want to be there, but they have no choice but to be there. So from a society point of view, I'll remind people that it's not looking at it strictly in the end of the 5 or 10% and trying to figure out how to eliminate that without understanding what having an impact on the other 90 to 95%. So yes, 1 is probably too many because it's an indication from our society that we are not giving those people the opportunity that they deserve to earn a living for them to be off the system. So those are my comments there.
Representative Nagel.
I'm going to talk in support of people on Medicaid. it's kind of like a lot of other things socially. You can't look at them as a homogeneous group of people. It's very heterogeneous. And the people that I've looked at or taken care of most of my career, people with severe disabilities, spinal cord injury, head injury, people like that are severely disabled, and they need this to survive on. That's another long story. But like the Medicaid expansion program, what it did was it gave insurance to a whole group of people that didn't have enough money to afford insurance, weren't getting it through their workplace. But almost all the Medicaid patients I see on Medicaid expansion actually are working, and some of them more than one job. So I don't think we have to really remember like who we're talking about. I did want to answer your one question because I don't know what the answer is, but I would be very uncomfortable if more than 10% of my payer mix was Medicaid. I think once you get over that number, you're really starting to strain your resources. And I would really like to work with the Medicaid managed plans to figure out a way to cut their demands on us, that we can cut our costs. So maybe we can see more than that. But right now, it's not a functional system.
Other discussion? Representative Palazzo.
We hear a lot that this bill won't fix all problems, but I think we are focusing on financing too much, and we need to focus more on science-based medicine. And it's a lot of financing, more than $500 million on the table. And we are getting too excited when we hear that 90% of it will come from federal government, so we don't have pay for it. But on one hand, like somebody still have to pay for it, and it's us taxpayers, but also it comes with a lot of strings attached. So when we talk about lack of standards, it's part of it. It's another federal program that is expanding, and sometimes it's not the best policy that goes along with it, and part of it might be regulatory caption, but also it could be just things move slowly on federal level, and like for example with dietitians, like New Hampshire dietitians maybe already up to current science, but they have to abide to the federal whatever it's called board that is very slow in implementing science that is changing. So I think we are trying to implement work requirements for participants, and it's good, but excuse my language, I think we need to do work requirement on ourselves. Let's work on amendments for this bill because there are some problems that we can try to solve with this great vehicle, and otherwise some problems like high prices, less price transparency, like all this math, like 50 cents on $1 compensation, it doesn't help our medical clients as a whole. Thank you.
Thank you. Representative Weber.
Mr. Chairman, we have spoken theoretically and extensively. We have spoken globally and specifically. And all of us have edited our comments because all of us could speak at greater length. My question is, what are we going to do now? Are we going to vote on amendments today? Do we want to give people more time to bring amendments? What exactly? Are you done? What exactly are we going to do going forward? Because we're not going to solve all the ills of society, and we have a bill in front of us, and we have a process, and I'm just trying to figure out what your plan is for us going forward? Are we going to deal with this today? Are we going to deal with it at a later date? What's the plan?
Sure. It is an early bill, as one might expect. And there are several amendments. Representative Merchant has one. Representative Cushman has a few, I guess. And it looks like Representative Leon may have a couple. So we're going to be meeting next week. I suspect we might even be meeting the week after. I guess it's 1 week at a time. So I'm willing to, I'm sensing that we're not ready to really dispose of this bill today. That's my sense. But I'm open to input from the committee. I want to consider everybody's position, and I'm thinking continue it till next week. But Representative Nattaratham, you had your hand up?
I would love to be able to read all the amendments in the quiet of my home. So I would enjoy if we could have all the amendments to take home with us tonight.
Sure.
And
That
then,
makes sense. Representative Leon?
Thank you. Some of it is that this is complex because I have one where it just says to repeal one certain line of it, but the rationale behind it and the reasoning behind that, I don't know if anybody's gone and taken a deep dive into RSA 126-AA, which is the statute that is our Granted Advantage plan, but that is a mess, to put it nicely.
but if I'm at home, I can look up that RSA and read it at my leisure. To try and make sense. And then at least if I can read all these ahead of time, I can come in, knowing what this is about. Further explanation would help. But I have trouble reading when it's noisy, when everybody's talking, whatever. I can just take this in much better if I can read it in the quiet of my home.
Given the importance of this issue, we need to consider every option and every
learning style,
every aspect of it, and
Thank
every
you.
direction of it, I think, so. Representative Shapiro.
I'm as guilty as anybody of going on and being philosophical about these issues. But I think as we get into the amendments, I think I would appreciate it if we had kind of a more structured kind of debate and then vote. I don't know whether that's being time limited or people just paying attention to be really focused on what they're saying, that it's directed directly at the amendment before us, but
We had some unstructured time. Some of our members had a meeting that they had to attend, and we didn't want, we had agreed with not having, any votes during that period, so that was part of it.
going forward, I think that would be a
Oh,
good
sure,
idea.
absolutely. That's how usually we have proceeded. Representative Polazov.
Me too. I appreciate and I'm thankful for those who give your amendments ahead of time for us to read it. But at the same time, some amendments they're based on how discussion will go and what other amendments already were submitted. So I would ask to allow all sorts of amendments. Like to submit them when they feel it's appropriate.
Well, if people can read them ahead of time, they can write down questions and it's a more meaningful discussion, I think. Go ahead, Representative Leon.
Thank you, Mr. Chairman. Part of it too is that depending on how this all evolves, I have some that I may not even offer. And I don't want to inundate you with all of these different points if there's some points that there's no appetite for. Because instead of trying to put it together and deal with this big wild woolly bill in one amendment, I'm trying to address each of the different points. And this is one where as we go on and have this conversation, it's one of those where it's very intertwined. And so that's why I just have a little bit of a reluctance of just sending all of these different amendments. And number one, I'm waiting still for drafting from OLS on some of them. And it's a process in order to do this because they do need explanation when they're introduced.
Representative Weber.
Nobody can make anybody else share an amendment if they don't want to share it. It's privileged until you offer it to the committee. So perhaps we could take under advisement Representative Nattarapham's request that I know I am very much in her camp. I would be much more likely to look favorably on an amendment if I've had time to read it, to think about it, to look up the statute, and perhaps to ask questions of the sponsor if I have them. But, you know, people can do whatever they want to do, and I don't see that we have a lot of control over it.
Well, let me ask this question. Does anyone object, those with amendments, sharing them if they so choose? And we can, or is it all or nothing? Is this like a?
We can't enforce an
No, I know, but if somebody wants to share an amendment and pass it around.
The more people who want to share, the better, as
Okay.
far as I'm concerned.
Is there any objections? Is there any objections to that?
No, I mean, we
Objections, or-
can't stop people from passing stuff out, even as we
Oh,
can't
so-
stop people
We need to
from
manage
not
it appropriately based on the amendment.
Right, okay, well. Yes, Representative Hall.
So in light of what we discussed this morning relative to RSA 1449, and in preparation for a potential amendment that hasn't been drafted, do we also need to change the makeup of that committee as well? And is that something we should be looking at, having someone draft ahead of time? No. On 263, there is a committee made up of various people, but the legislators are not in the majority. Do we need to address that to be compliant with
I
RSA?
would say. Representative Weber?
I think our researcher.
Oh, I'm sorry. Here she comes.
So that clause that says notwithstanding 1449 has been a workaround, it is illegal. That is what people use to get a commission that is not the 15 that was put in 2021. We hate it, but it's legal.
Oh, is it?
Yeah, it is.
So it does not have to be a joke.
And it's the purview of, I mean, we are trying with the committee of commissions to try and keep it at an unwieldy, but it's not like it would pass the way it was. It's a problem for us, but it's not illegal. It's not.
So we do not need a statute or an amendment?
No, you don't. Although they try to enforce it, but that's a workaround.
So based on practice and legal opinion? Is that based on practice?
So
Established
the
practice.
drafting attorney, like, that's just what they've been doing. It's one of those loopholes that we're trying to close, but have not. So if that makes sense, like, it's not necessary. With all you have going on, it's not necessary. If you wanted to do it, I just feel like it would add a lot more work to your table.
Thank you. Apparently, we do not need to take care of that, Representative Hall. Apparently, there's a loophole involved that they're working on closing, but it's not something we need to do, so. Hey, Representative Leon.
Thank you, Mr. Chairman. But however, if we feel that it's good policy to not give, notwithstanding a certain RSA that was designed to control this type of creep of commissions from being a legislative effort to one that's more community-based, that if we believe that we should stick with the intentions of RSA 1449, then it would be a good idea to draft an amendment and to do that.
I guess the question is, how many amendments do we want to consider?
All of the ones that are necessary to do our work.
That's vague enough. Representative Weber.
I am recalling a committee where there were 36.
Okay, I hope we don't beat the record. Other discussion? All right, so we'll continue 240 till next week. Is that a fair? 263, rather?
And Mr. Chairman, there
yes.
was a question of the makeup of the committee on 240 while you were out
Right.
of the room. It currently consists of Representative Leon and myself.
Right, there's two members and Representative Merchant, I hear you might want to be on that? Okay, very good. Representative Nagel, you're busy on Tuesdays still, as I understand it?
That's what my office says, yes.
There's a meeting at what time, 10:30 next Tuesday?
Were we able to secure a room for that, or are we in the process? Okay.
Senate Bill 240.
Mr. Chairman, we have usually in this committee allowed members who are not members of a subcommittee to sit in and participate. They don't participate in the voting, but, sorry? Okay.
No, we can't do next Tuesday.
No, I'm suggesting that if we have two people already and other people are sort of wanting to participate around the edges, they're welcome to do so. I don't understand what you're talking about an email.
Oh, to know exactly what time.
These have to go in the calendar. So you read your calendar, and the calendar says when it's meeting and what room.
Okay, and again, I do, Representative Leon.
Thank you, Mr. Chairman. This is one of the areas that is, I think, entirely nonpartisan. I actually would really like to see a subcommittee of myself, Representative Weber, and Representative Merchant. If there's no one else wanting to join us, that's fine. But I think we do need to look for all three of us to be available. So if Representative Merchant isn't available on Tuesday, I know we'll meet on Wednesday, we'll have session on Thursday, we'll probably need to sleep on Friday to recover. So it may be able to go into the following calendar. Does that work with you?
Could the other option, could we possibly meet on Wednesday before this meeting?
No.
Okay, thank you.
Okay, so are we prepared to notice a meeting right now or just push it off to the next calendar?
I think we'll notice it in the following calendar.
All right, so it won't be in this calendar. Okay, any other business to come before us today? I'm not, Representative Leon, I'm not sure what, everything that may have happened while I was gone earlier, but.
We had skipped over Senate Bill 239 because I think our two of our more knowledgeable committee members on that had to go to their other meeting. So I think that it would be good to see the amendments that Representatives Nagel and Merchant, that Representative Nagel has on Senate Bill 239, and to consider that even if we do end up continuing it. That would be my advice. I don't know what you'd like to do, Mr. Chair.
No, that's fine. Sure. Just trying to get caught up on and we talked about it briefly in the hall, but.
Yes. Lots of moving pieces today.
Representative Shapiro.
I just want to get some clarity. I have another meeting to be at. So are we not going to exec any more bills today, or are we?
Well, I was thinking of seeing where 239 ends up going, but
okay.
you have to leave?
Well, I'll stay if I just needed to know.
Okay. I mean, Representative Nagel has 3 amendments, so I guess we've continued so much today, I would hesitate to guarantee we will accept further bills, but.
What we were told when you were out of the room was that there was more discussion to be had even beyond these amendments.
Okay.
So as one who came thinking that we were actually going to do all of the bills today, I think we're at a point of diminishing returns, frankly. And we have till the 11th for 2 of the bills, and we have till June 1st for the rest of the bills. So,
I mean, in respect to Representative Shapiro's schedule, I'm happy to, Representative Weber as the ranking member, I'm happy to defer any further votes today.
I just think that if we were told that there were more things that needed to be done with 239 in addition to what's being passed out now. And Representative Leon is nodding her head, so I think she's one of the people who wants to do more with it. So I don't see how we can vote on it today.
Okay.
And we have plenty of time, so
All right.
perhaps coming back when we're all fresh is, and have read as much as people are willing to share, might be a good idea.
That's fine. We'll defer any further voting then.
Can we also defer any further discussion, or are we going to have more discussion?
Well, Representative Nagel, is there anything you want to say about these amendments? That you want to give people a chance to read them and
Microphone.
microphone? Sorry.
If I could just advertise them up front, 2 of them are extremely basic, but the one that's the most important or the most challenging is on the whole definition of harm reduction and should this be in the bill or not? Because the word harm reduction is not defined in statute anywhere.
I've only received two, by the way. Is the third one?
No,
going
there
around?
should be a third one coming around.
Okay, I haven't, the third one hasn't made it yet, so.
If,
Oh, I'm sorry. My bad.
Thank you. I'm sorry to interrupt you.
No, it's all right. I mean, there's three amendments. The first one, as you quite are aware of now, I was very concerned about the changing of the word of abuse to misuse and how that could adversely stigmatize people in pain that actually have legitimate use for these medications. So Ms. O'Higgins and I sat down and crafted a statement that would allow them to be accepted from that definition. When Senator Waters brought up the bill originally, he had a CME requirement for doctors. He was not aware that it already existed in rules. So what we did was we just took what he wrote, X'd it out, put in what's in rules. And actually what's in rules is substantially more difficult than what he recommended. And then the third one is, again, the whole issue of harm reduction is very important for several people in this room. And Senator Waters came up with a recommendation for defining that. So I'm submitting that on his behalf.
Okay, thank you. Are there any questions, initial questions on any of these? I realize many of you want to read them and review them and perhaps do some research before we get into them in more detail, but any preliminary questions right now for Representative Nagel, Representative Leon?
Thank you, Mr. Chairman. And Representative Nagel, in light of some of my recent personal events, I'm just curious if there should be any protection for people who are end of life, as well as chronic pain patients, so that they can get appropriate pain management if we're more worried about their either ease of suffering while trying to survive versus an addiction that they'll never live long enough to see.
Yeah, I'm glad you brought that up. I was hoping that the thing we came up with would accept them from that would be sufficient, but see what you think, and if it's not, we should talk about it. I mean, it's like a huge issue. This whole concept of opioid refugees, when we met with the speaker, that was one of the issues that came up, but we estimate 15 million Americans benefit from long-term opioid therapy, and about 90% of them can't get access to it. So guess where they go? They either commit suicide, they go without, or they go to the streets to get it. And we're seeing an unacceptable rise in suicide in people with chronic pain. You brought up end of life care, and I know you have a personal experience with that, and so do I. And it's just, we're actually seeing adverse palliative and hospice care now. So it's extremely important when we go through these bills that we make sure that that group of people is not adversely affected by this. So that's kind of my hope, and we need to make sure that that language gets perfect. So if it's not, let me know, and then let's make sure it is. Now that I know how to make an amendment.
That's a dangerous skill for you to have fire. Representative Weber.
I just wanted to add my voice to that concern. I had simply assumed that when we were talking about pain management, it would also adequately cover end-of-life issues. But one of the fortunate things about my late husband's illness was it happened from 1996 to 2000 when people were willing to prescribe him limitless numbers of MSIR 15 so he could just take exactly what he needed when he needed it and didn't have to worry about either having a continuous medication which kept him hazy and sick when he didn't need it. And we were lucky then, and I know that that doesn't happen now, and I am hoping that we can get back to the point where end-of-life care really is something that we honor and help people deal with their medications in the way that works best for them, because some people do need the higher levels and higher doses and continuous doses, but some people really didn't. And I know I would never have the number of pills that I had on hand in the house now. And the only mismanagement we ever did for those pills was that the disposal method at the time was you flushed them down the john. So I am responsible for many eight-legged frogs in the lower Connecticut River Valley, and I'm really mortified about that. But the care was really good care, and we need to go back to it.
You both bring up a really super important point, because one of our stakeholders is New Hampshire Hospice and Palliative Care Organization. I've worked with them for a long time, and actually my origins in medicine were end-of-life care. So these are all important issues to me, but one of the things that we have been able to do very successfully so far is exempt end-of-life care from a lot of the statutes that we've done. So far we've been really successful. The problem may be that, you know, I've seen if you get the wrong person in the wrong place at the wrong time, you can screw that up. So it may be important that we do specify that. I think, you know, the more I think about it, that is a good idea that we write that specifically. Thanks for bringing that up. That's really helpful.
Representative Hall.
Thank you, Mr. Chairman. I just passed out one of the amendments. I have several, but one of the ones that is eligible to discuss. Please note that on line 14, the word "and" needs to be replaced with "or." The goal here was simply that if people are on this program, right, they're either seeking help to get training, this is part of this transitional thing, or they're working, not both. Minor drafting issue, so it's not ready to submit with this number, but we can get that fixed.
Other discussion? We did actually do a lot today. We made it, and I'm serious about this. We made it through 4 bills. We had some really good discussion on others. So we'll be continuing the other 5 until next week. The ones we did complete today were Senate Bill 85, Senate Bill 87, Senate Bill 171, and Senate Bill 238. So
I believe 240 will be continued to be at the 10th.
right. I mean, not that we can't do anything with it, but yeah, there's a subcommittee. So Representative Leon.
Thank you, Mr. Chairman. I think if you may remember last week, I had objected to the harm reduction language. In my minority report, I do have language about drug checking stations to make sure that fentanyl and xylitol, which is the tranq, can be identified, both so that users aren't having unwanted adulteration and so that our public safety and our public health can understand what's on the streets. I've spoken with former chairman of the Police Chiefs Association around that. So I will distribute it to everybody. I think that narrows it down to a pressing need. And so I'm hopeful that I'll have some support on that. I just wanted to mention that because that's part of the same harm reduction we're looking at, but it's just narrowed in because of the challenge of the definition.
So is that a floor amendment then for that bill?
Yeah, it's the minority amendment, so it'll be in the calendar, but yes, it's one that's on the floor.
Okay, that's fair.
Any other discussion on?
It's either a minority amendment or it's a floor amendment. If it's a minority amendment and in the calendar, it's a minority amendment, not a floor amendment.
Thank you for that.
Floor amendments are always in the seat pockets, right? Usually.
Usually, yeah.
Any other discussion on any of the business before the committee on these bills? If not, we'll adjourn until 9:30 next Wednesday. Thank you.
You know what's fun about So I was out visiting my friend in Dallas. You and Turk are sisters.